or they can't change, they can't swing the goalposts.
All right, we're good.
So you gonna come on either on Thursday then too?
I don't know. Yeah.
I'll see more of you guys then.
See where things are at my office.
Yeah.
If I can make it. And then, just in case one goes out. And then when you guys are done, have a chat in the office after about caucus on the 20th or certain things. And then the bills that you want to submit. Okay. Yeah. Yep, so just whenever you're, maybe we can represent it. Okay, perfect.
And Kelsey, I got sent me an email about that. Did you send it to me?
That was probably Alice.
Oh yeah, yeah.
Oh, yeah,
Okay.
I feel like you got
Yeah, I can do it. That's fine. That's different reasons that could be.
Yep, we can chat about that and then have kickouts that we can get.
Yeah.
In all the packets.
Yeah, kind of just the highlights or overview.
Yeah.
Yeah, I can. I'll bring that one some lunch. Then people want to talk about the strategy.
No, not yet. Sounds good.
So we're gonna just we meet at 12. At least on 12:30.
Yes.
Okay.
Yes. Right. 12:30 or one of
I
those.
think I have an email they moved up on.
Real big and
And no lunch.
but anyway, you're the big girl.
Yeah, 12:30.
I think that's what the email came.
Good morning, everyone.
We're gonna need some more leadership.
Welcome to the Health Policy Oversight Committee. I'd like to call the meeting to order. And just kind of talk a little bit about the agenda. We're going to review the SF 2418 provisions with DHS, the tiered support community living rate work group, the health home work group, and the level of care sampling findings. And then we're going to do a session on the process improvement work group. And then 10:30 we'll take a break. Then we're going to take up the July transition information. And then have the MCO updates from United Healthcare and Delta Dental, as well as the MCNA Dental. And then at 12 noon, we'll have time for public comments from 12 to 12:30. I'd just like to read the Health Policy Oversight Committee charge, that is to provide continuing oversight for Medicaid managed care, ensure effective and efficient administration of the program, address stakeholder concerns, monitor program costs and expenditures, and make recommendations to the General Assembly. So I appreciate all the efforts that have been made to prepare for this meeting, and as we work through our Medicaid, some of the things that we've gone through, I appreciate the efforts to make this work better and to try and work out any issues that may arise. And I just look forward to hearing some of the things that we're looking at to try and make things better. So, Representative Heaton, do you have some comments?
Not really. I think you covered most everything. I mean, I think we're going to deal with some subject matter today in our agenda that kind of during the session, the side session, create a lot of concern and create a lot of interest. Spoke with a lot of providers, spoke with the department, and on a couple of these issues, we asked the work groups to be formed and sit down with our providers in the department, try to work this out and come forward with a report. I guess this is my last meeting officially as a representative, so it's kind of a different moment for me. And just like to take the opportunity to say thank you for all that you've done for me, all the support that you've given me, all the information that you passed on to me. It's been great working with all of you, and I wish you well in this next session. And with that, let's get started.
Okay, does any other members of the committee have any remarks before we start? Okay, thank you, Representative Pete, and I know we're all going to miss you greatly, so it is kind of a different meeting for us too. So at this time, I'd like to ask DHS, Director Randall and Director Foxhoven to come forward and review the 24-18 positions. Welcome.
Good morning. Thanks for having us here. We're going to be a little squeezed here because apparently LSA is going to be filming it, so we want to sit close together. So it's not that we're nudging you. This is where they asked us to be. We're going to start today on the tiered rates, and so I want to do just a little bit of an introduction and then refer to Director Randall to really get into some of the weeds on it. As you know, the 2017 legislature directed us to implement the use of tiered rates as part of House File 593. It was to be budget neutral with the goal to standardize and more appropriately reimburse providers based on the severity of needs of the individuals that they serve. You know, what we want to do is make sure that we incentivize people to take the most needy patients and not only the least needy patients, and frankly, the most needy are more costly. There were previously, before we originally went to tiered, there were 5,000 different rates with no relation to the severity of the needs of the people. It didn't make a lot of sense. Tiered rates were then first implemented December of 2017, and the legislature and governor appropriated an additional $3 million of state funds for tiers effective July 1 of 2018, so this fiscal year. The Association of Community Providers, the state's largest trade association for disability service providers, was supportive of a shift to tiered rates, and when they were being developed, members of from the association as well as service providers participated in a work group to kind of work on developing those tiered rates. So where we are today, I'm going to turn it over to Director Randall to give you some further updates on it.
It's kind of a tight squeeze here, but I'll do my best here. I'll use technology. So I'll go over this at a high level, and I think if you would like to, after that, if you want to pause and ask questions before we get into the health home, or would you like to move forward after that? Questions?
I believe we'll take questions and then
That's fine. All right, thank you. So really, the original work group reconvened last month for the legislation that was passed last year to review tiers and make recommendations to the legislature to refine as needed. It also had language in the legislation that if it were budget neutral, we would go ahead and have the opportunity to shift those funds if that was indeed necessary and indicated with the study. We showed what the actual cost of care is for the members. So one of the important things I think from this review is that we did look at, Optimus did look at more than 116 cost reports that were submitted by the community service providers, which represented about 91.3% of the entire spend. So it was a very good sampling of those cost reports and those providers. We have been making, as you have heard me say prior, several exceptions, many exceptions to a policy relative to the ID waiver, and that really was around members who were not falling within Tier 1 through Tier 6. They fell outside that, so those exceptions to policy were approved. This, I believe, will significantly reduce those exceptions to policies as we shift those funds. The work group had a chance to review the findings and agreed with the recommendations. So we met with the work group, we walked them through, the actuary and myself walked them through the recommendations, and it clearly indicated that we needed to shift funds from Tiers 1 and 2 to Tiers 5 and 6. So that's what we were doing, and that's the recommendation. And since that is a budget neutral exercise, when we met with the group, we wanted to make sure that we had the opportunity for those members, providers in Tiers 1 and Tier 2 who are going to get less reimbursement to have opportunity to understand that within their business model and their budget. But we also didn't want to wait long enough that Tier 5 and Tier 6 continued to lose that money, and we would have to continue with those exceptions to policy. So what we agreed upon with the work group was that we would move forward with those shift in funds and those higher rates March 1st of 2019. I will also mention that the report was submitted to the legislature on Friday the 14th, so the detailed analysis is out there. So with that, I'll be happy to answer questions.
Okay. Senator Reagan?
So thank you for your presentation. Was there any consideration of transportation in these rates?
Transportation was included, so the analysis, there was $13 million of transportation in those standard rates, so that was part of the component here of the study that Optimus did conduct, yes.
And was it beneficial to all of the rates then, would you say?
I'm not sure if I understand what you mean by beneficial. We allowed for the transportation costs that are already in the standard tiered rates.
But there is no separate transportation rate, really?
No, there's not a separate rate for transportation.
It's in the
those
rate.
dollars are included within the tiered
That's
rate
what I
itself.
wondered, if there was any consideration for a separate rate.
No.
Okay, thank you.
Representative Pence?
Thank you, Mr. Chair. Thanks for your presentation, Director Randall. So I am hearing from some providers who don't disagree that Tiers 5 and 6 needed additional or higher allocation there to meet the needs. But they're also struggling with an underfunded system in Tiers 1, 2, and 3. And actually got an email from an entity that is going to be at a loss of nearly $300,000, and that is going to be a challenge for them, who's already extended their line of credit to maintain their doors to stay open to about 300 people with intellectual disabilities. And I'm just trying to figure out how you reconcile with potentially folks getting a reduction of services or losing them altogether.
Sure. And maybe I can answer that. Remember that we based it on cost reports. And so what we were able to determine based upon actually what the cost the providers had was that we were overpaying on 1 and 2 and that we're grossly underpaying on 5 and 6. And so when a provider, I'd gotten that contact from the same provider, said we're going to lose $300,000, it doesn't mean based on their cost projections that they'd lose, it means that they would get paid less. This was still based on their cost projections. And so the first thing I tell you is that what we're really doing is right-sizing this to make sure that the people we were grossly underpaying are going to get more money. The people that were overpaying based on their own costs, we're reducing it and giving them time to react to it. The second thing I really want to emphasize is what we have done by overpaying on the Tiers 1 and 2 and underpaying on 5 and 6, we have incentivized people not to take the most needy members. And we have incentivized people to take the least needy members. And that just isn't the right thing to do. The right thing to do is to make sure that we care for the people with the greatest needs. They need our help the most. And this does it. Again, since it's based on cost reports, we haven't just pulled the number out of the air. We've actually looked at what does it cost for them to serve these people. And we have been overpaying. Now, we're not going to go back and ask for money back from those providers, but we want to adjust it down to what their costs really reflect and adjust it up on the other tiers.
So for how long has the department been overpaying providers then?
Well, I think that what we have to look at is the initial analysis and the work that the original work group did in working with Milliman to move from those 5,000 individual rates to the tiered rates. That's what happened when they went to Tiers 1 through 6. I can't speak to that analysis, but I can speak that when Optimus did this, we're looking at the claims experience, and when they grouped them into low acuity and mid acuity and high acuity providers, when they shifted to the standard tiered rates December 1st of 2017, Tiers 1 and Tier 2, which were the low acuity and mid acuity, they saw anywhere from 8% to 22.4% increase. And Tiers 5 and 6, the high acuity, saw a 10 to a 12% decrease. And this analysis is in that report too. So when we did this analysis and working and see what would be the best scenario is moving those funds from 1 and 2 to 5 and 6.
Sure. I'll have to follow up with that provider and a couple others that have contacted me as well to see where the kind of discrepancy is. But I would also concur with Senator Reagan that I wish that there was a separate line item for the transportation, because that is really hurting our providers. So thank you, Mr. Chair.
Okay, so do we anticipate that this is going to be the final tiered rates, or will we have a review of them later, or what's the situation there?
Right now, when you read the report that is out there, the actuary wanted to make sure that we compared apples to apples with the previous analysis. So the increase of that $7.3 million from last legislative session was removed, so this analysis could be accomplished. Before this report was completed, this does not include that $7.3 million because we want to make sure we compared apples to apples. So we will be putting that funding back into the tiered rate. So on average, across the 6 tiers, you will see about a 2.4% increase from what's published right here.
Okay.
And I think from my perspective too, and I work with, we'll work with the associations and with the work group as well. Optimus did make a recommendation too, kind of taking a look at the low acuity 1 and 2, 3 and 4, looking at residential care facility. Do we need to do additional analysis to determine if those are the right tiers? Is 6 the right number? And I don't have the answer to that, but I think we'll continue to do that analysis as we move forward as well.
Okay, thank you. Senator Reagan, you want to?
Just a follow-up. Can you briefly just tell us what goes into that cost report? Is it the whole reflection of the cost of doing business, or is it just the service?
I don't have a copy of the cost report in front of me.
But just
I would assume it's
from
the
a
cost.
10,000 foot.
I assume it's the cost of doing business as a community service provider, indicating your cost of not only providing services, but your administrative cost as well.
It would be including the administrative cost.
I believe so.
Okay. Could you follow up on that?
We certainly can.
That'd be great.
We
Thank
can
you.
certainly provide you a copy of the cost report.
I just wondered if that was included. Thanks.
Any representative forms?
Amanda? I don't think so. I don't-
Question I have, since the patients who were in the tier 5 and 6 for the past probably year or so, and your statistics show now that the providers were underpaid anywhere from around 10% roughly. Is there any way, or you have any plans in place to make them whole or bring them up to where they weren't in the situation they're losing considerable amounts of money?
No, there's not, on the one hand. On the other hand, this was the group that we were making a lot of exceptions for. And so we were making exceptions. We'd go out and Mike and I together had sometimes gone to some of the places and said there's no way they could care for these members for what we're paying. We made exceptions. Some of those exceptions, what we're finding out when the tiers are proper, they'll actually get paid more than what we made for an exception. And so, no, we're not going to go back and reimburse them, just as we're not going to go back to the lower tiers and ask for money back. But I think most of the people that are serving people in the higher tiers are just happy that we're aligning the cost properly with what it costs. And so I think most of them wouldn't expect us to go back. They're just thrilled. They've been telling us for a while we're being underpaid by a lot for people with the greatest needs.
Representative?
So I just want to review the process that you went through to come up with this and then ask questions. So you had Optimus or whoever they were do an analysis of the cost report. Is that true?
That was part of the data, yes.
Yeah. Okay. So when they took a look at the cost reports of the level 1, 2, and the RCFs, they determined then by looking at the cost reports that as a result of your shift to 5 and 6 and the reductions in the 1, 2, and RCF, that the rate then that would be received by the 1, 2, and RCF would be adequate and meet their costs that they submitted to the option, whatever it is.
There is a table and report that you'll be able to see, and I'll just briefly walk through it, that's exactly correct. And they look at the profit loss under adjusted standard tiered rates. So when you take a look at the low acuity, it's about a 0.6% increase profit still. Mid-low acuity is a 14.6%. That's down from the 22.4, so it's still a significant increase. Mid acuity is a 1.6% increase. And still, the mid-high acuity, it went from a 10% to right at an 8% loss. So they're still not at that particular point. But we went through many different scenarios on how we would go through and adjust those rates. So yes, you're correct. And overall, it's about a 1.4%.
But, okay, so in looking at that then, and we look at the total dollars that we have committed toward those providers, the rate that was being paid before you did across the board originally, everybody got the same amount of money originally, increase. The original amount before you added the extra money, what is there in doing your restructuring and going to 5 and 6 and affecting RCS in 1 and 2, is the rate that they're now going to receive after this rearrangement at least equal to the amount that they were receiving before we inserted our appropriation? You know what I mean?
I'm not sure I quite understand. I will tell you that, again, this analysis in this report does not reflect that 7.3 million because they want to make sure they were comparing apples to apples. And then when we did include last year that 7.3 million, it was not an across the board equal amount across all 6 tiers. There was a proration based on that tier. We are going to put back that funding of 7.3 million, and that'll be about a 2.4% increase of each of those tiered rates that you currently see in that report.
I guess I just want to make sure that the rates that providers were originally receiving before we made the appropriation that created the increase, that the rate that they were being paid at that time has not changed as you rearrange the deck sheet.
I don't know. Are you asking that prior to the inclusion of the 7.3 million, the original work group, and those rates that were established?
Yeah.
Are they at least that amount? I do not know. But obviously, if we're shifting monies from 1 and 2 to 5 and 6, and it has to be a budget neutral process, there may be those providers who have less of the reimbursement.
I understand. I'm trying to get a handle. I'm being told that the rate now that some providers are going to get paid will be less than the amount that they originally were receiving before the 7 million went into the rate structure.
I don't have individual provider rates in front of me that could potentially
I think you need
be true.
I mean, I think you need to look at that to make sure that our providers who are going to be able to meet their costs on your new arrangement. And
Well,
I'm concerned if one provider hits a significant amount of money that he's going to be doing without. And I can understand if he received an increase and now you're moving it away and moving to 5 and 6, which we wanted in the first place. But I just don't want the man and his organization to go below where he was before we put in the 7.
Maybe I can just help a little bit. You can't do a shifting that's cost neutral without somebody losing some money if somebody else gets some money. So if you're going to provide more money to 5 and 6, that money has to come somewhere if it's budget neutral. And so of course, and when we based it on cost reports, we took the cost reports and said we wanted to make sure that they don't lose money by serving 1 and 2. They lose money based upon what they were getting before this adjustment. They'll make less money, but they shouldn't lose money based on their cost reports. And so anytime it's a cost neutral and you're going to add more money to the upper tiers, it's not hard to figure out the lower tiers are going to get a little less money. There's no question about it.
I'm just going back to the time when we knew we were going to have this $7 million. And we worked with the provider group, and what we wanted to do was put this money toward 4, 5, and 6. I remember. And we wanted to alone. That means they were going to get paid the same amount that they were receiving, and the money was going to the upper level. Now I'm being told that by providers, not all of them, but one provider anyway, who's telling me that the amount he's going to receive, the rate for his RCM, will be lower than it was when we wanted to add the 7 million to 4, 5, and 6. He's going backwards and below where he originally was. That's the point I'm trying to.
And again, I don't think he would even know that yet because our report didn't include the $7 million added back in. So it included what it would be without that. Then the $7 million will add to that rate of what we proposed on the tiers.
Well, I just, if that, you know, when you look at the numbers and you find out if that is true, then I'm just hoping that you might, before the final, take a look at exactly how you're affecting some of these providers by, if it's true that we're digging the dirt below the surface and moving it over, you know. And we're not
Actually, I don't think, again, remember that we've been overpaying on tiers 1 and 2 and grossly underpaying on 5 and 6. And so frankly, if you want to say, let's hold 1 and 2 harmless, you will continue to grossly underpay for the people that are serving the most needy. I just don't think that's where we want to be.
Thank you.
Is that okay? You guys, you still want to represent me?
Yes. Thank you, Mr. Chair. And I know that Representative Heaton and I look much alike, but so no, I actually just wanted to, so Representative Heaton, your comment was actually what I was trying to get to earlier. You just articulated it better than I did in regards to the rates. And that's what I am hearing as well, is they're not going to be paid the same. 5 and 6 will, but 1 and 2 or others will not be. And I don't think that was the intent of what we're wanting to do. I would also ask that our incoming chairs, Representative Fry, and I think Senator Costello, you're also chair of HHS for, no, but at least Representative Fry.
Okay, so I'm going to be co-chair of the budget subcommittee, but Representative-elect Miller Meeks is going to be chair.
Okay. Well, I would just ask that maybe we have these folks come back and provide more detail on the tiered rate for our budget subcommittee, because I feel like we're woefully lacking in some detailed information and questions that we all have around here, and I'd like more. So I'm just putting that out there.
What
for
specific
our budget.
question may I answer for you?
I would say more detail into those tiered rates and which ones are going to be the losers and which ones are going to be the
We
winners.
certainly can't
because
share individual detail of the providers.
I would like more
I
specific
do have that
information on
detail.
what your rates are.
I think if you look at
The report.
the report we just
Very
filed on
detailed.
Friday, and so
So-
if you look at the report, it's very detailed and gives you, I think, what you're asking.
Yeah, well, I think maybe going over that report would be helpful for our budget subcommittee meeting. Having, you know, a PowerPoint or something so that we can follow along right with you. I know you just kind of mentioned that you're not quite sure how some of the providers know some of where their rates will be. I mean, obviously they know something already, and so they may not have that 7.3 million in, but they're also going to be wondering, what does that do to them? Does it help them or not? And I'd like that additional information as well.
But we've worked with the providers as we've done this, so that's why they're saying they've been well aware of what's going on, and we've been keeping them in the loop.
We're happy.
Okay, Senator, do you have a tiny little question?
So, at the end of the day, do you think that any of the people will have lack of services because of that? You think everyone will continue to provide services, is what you're saying?
I think that
Even if it's a reduced rate?
I think that with tier 5 and tier 6, absolutely, those have been underfunded for a long time.
Right.
And I do think even in tier 1 and tier 2, they will continue to provide the services.
Okay. Because I think at the end of the day, we don't want to see anyone losing services.
No, we do not.
I think that Representative Heaton explained how the process was going to work, and I believe that we were all under that impression.
And I just think, honestly, I'm just going to tell you, honestly, if we'd have continued the way we were, we'd be losing services for the most needy people.
Right, and that
Because
was
we
the
are
additional
disincentivizing providers to take care of them. We need to fix that. The most needy people need to get services.
Right,
Agree.
but we also were adding additional resources to help that out. Thank you.
Okay,
Director, I just want to let the directors know that in all my line of questioning, I do recognize the difficulties in the 4, 5, and the 5 and 6. And I'm really happy that we're moving the money the way it's supposed to be. I just don't want the movement to necessarily penalize. And when I say penalize, I mean at below their cost. It's not whether or not originally they were at a good rate and were doing well. The deal is that I just don't want them to endanger the services that they're providing. Thanks.
okay, thank you all. Let's move on to the health home work group now.
Right, the Health Home Work Group, I will share also on Friday the 14th, this report was submitted as well. It's rather lengthy, very comprehensive. There's a lot of statistical analysis that the biostatistician conducted. So I'm going to go at a high level and then I will answer the questions as you have. So as you know, there are two types of health homes. There's a chronic condition and integrated health home. Providers receive a per member per month for those services that are provided. As of September, there were about 22,000 members, 2,000 in the chronic condition, and about 20,000 in the integrated health home. The original integrated health home was launched in 2012. That was the chronic condition. Integrated health home was launched in about 2013. As part of the 2018 legislation, the department was instructed to review the 2 state plan amendments applicable to health homes and conduct analysis of the program. We organized a stakeholder work group that included about 20 providers, the MCOs, the department, and other staff. Work group met twice in October. The review was conducted looking at the interaction between 3 categories. So we looked at the structure, the process, and outcomes of the program. The structure was assessed by reviewing org charts and staff training certificates of the providers. Processes were reviewed and assessed, going out and actually looking at member file documentation and having it, in some cases, that information sent to our evaluator, and how were those services actually being delivered to those members. Outcomes were measured through value analytics using 3 years of Medicaid claims data to compare the total Medicaid cost for health home members versus similar non-health home members. So there was actually a treatment group that was compared to a control group. And you'll see the process that they went through to do that is very detailed, very comprehensive, very statistical. As far as the findings, and you'll find this in the executive summary as well, it was clear that providers admittedly did not fully understand the requirements of the 2 state plan amendments. There were inconsistencies among the providers regarding documentation of all the requirements. Per member per month payment process is disconnected from the delivery of health home services. So I believe it was 88% of those PMPMs were relative to only 2 components of the 6 core services. There were per member per month payments that were made for members who no services were provided. That actually, in some cases, 90 days or more where there were no services and the PMPM continued to be made. The cost of care for integrated health home members is significantly higher than similar Medicaid members who are not enrolled. The chronic conditions and the non-chronic condition enrolled members basically a statistical indifference, so there was really no difference in that cost. With respect to next steps, the department, along with the work group, are going to continue to review the state plan amendments and consider potentially combining those 2 state plan amendments. There are a lot of similar requirements in those 2 state plan amendments, so we're going to look at the possibility, does it make sense just to have 1 state plan amendment for integrated and chronic condition health homes. We're going to work together with the MCOs, provide better communication and technical assistance for those providers, and we will continue to review for health determinants. So when I take a look at the data analytics in this particular review, it was cost. So when we take a look at cost, as I said, integrated health home members cost more than the control group. The other group was basically statistically no difference. However, what I recommended when we worked with the work group and how we're going to move forward too is we need to do additional data analytics relative to quality outcomes, not just dependent on cost, but what are the health outcomes that we're seeing between the control and the treatment group. So that's something that we will continue to do as we move forward with this. So with that, I'll be happy to answer questions.
Okay. Go ahead, Senator Mathis.
Thank you. Again, thanks for you two for coming here. So, just in looking through here, I read this over the weekend. I saw that the data showed that about 8% of the Medicaid members did not receive service, but 89% of the Medicaid members were connected, you know, with a personal provider within their health home. And to me, that looks like pretty good evidence that it works. And I also looked at another piece of data that showed that there was about a $22 member saving, you know, per member per month savings. And then if you take that by about 20,000 Medicaid members in integrated health homes or health homes in general, and then multiply it, it's about maybe a $5 million in savings. So with that material and the evidence that was provided to you too in the work group, it sounds like it's working to me. So what with that data, what's the flaw that you see?
Well, I wouldn't describe it as a flaw. I think when you take a look at 8% of EMPM's members had no services and per member per month paid, that's the flaw. We can't have members or providers getting per member per month payments and no services provided. That's not how that works. CMS will not allow that. That's something that we're going to have to take a much closer look at. You also have to take a look at the 89% where it says members were connected and really define what connected means. So it doesn't mean they were provided services. So you have to go out, and that's where I talked earlier about the discrepancy and consistency among the providers as far as that care coordination and that connection. Sometimes it was a simple phone call, maybe it was an email that was sent out. So exactly what does that mean? So yes, directionally it looks good, but I would not draw that conclusion at this point that that's a success with the health home because of those. So we have to do additional analysis to clearly get down into the weeds just a little bit more, and we simply didn't have time to do that in this particular study. One of the lessons learned from this is that we just need to do additional analysis, and that's what we're going to continue to do. We're going to take that report, we'll work with the work group, we'll work with our actuary, we'll work with others to say, okay, here are components that we're seeing in this. Now let's dig down deeper and understand truly, is it being successful?
Well, prior to this work group, you were getting information on health homes, and I know that I wish Senator Shelgren were here. He did sponsor a bill or put together a bill that, you know, asked that we would, you know, perhaps, you know, stop this, kind of put it in pause to take a look at if it is really working, and then to help create the work group. So there was a lot of attention to that this last legislative session. And prior to that, I remember when health homes were set up, Jennifer Vermeer was here as the Medicaid director, and DHS asked several of the providers to do a pilot, as you had indicated in the historical reference to health homes. And there really wasn't much guidance from DHS in the setup of that, or from IME in the setup, and so a lot of providers did you know, do the best they could to enroll certain members, but were given really very little dependable data because of the Medicaid population that was going to be enrolled in that particular type of service. And so from that point, from the time that it was set up before that next fiscal year, I think that was 2013, did you say, or 14? So it was set up, it was before Director Steer got here. So what then happened between 14 and now that you don't have that data or can't tell if it works or not? And that a work group didn't bring that about. I don't understand that you don't have enough evidence to see that it actually works.
Well, I think that, and I appreciate you reading it over the weekend, I appreciate that. And I think you'll see in that report that that's one of the recommendations as well. I don't believe that, my understanding, I certainly wasn't here, and I can tell you a few months after I got here, I believe requested and recommended we're going to pause with respect to integrated health homes and do exactly what we have done, because we needed to do that. I think that there were 3 phases in the rollout. I think phase 1 probably had more exposure, more education, more training relative to providers, and you got to the 3rd phase, probably wasn't as much. So part of the recommendations in this report, as you can see, is when I talked earlier about better communication, better training, better guidance, better oversight from managed care organizations, and IME toward those providers and working with those providers so everyone understands what the expectations are. I think that's an opportunity for us, and that's an opportunity for us to edit those state plan amendments to put clear expectations within those state plan amendments and go out and train and provide that guidance to those providers as we move forward. We will continue to do the data analytics relative to determining if we're adding value with the health homes. As I mentioned earlier, looking at pure cost is not the only way we need to do that. We need to look at the quality of outcomes. Are there ER utilizations going down, inpatient going down? Are they seeing their physicians more? How about the behavioral health side? We need to dig into the data and understand that, and that's what we will continue to do.
Okay. So while you're digging into the data, and I think I asked you a question during the last meeting about dental, and at the end I said, would you make that decision solely? And you said no, certainly you'd take into account what, the data again, and it's a legislative process. So with this, do you still see this as a legislative process that we are involved as legislators in making the decisions if health homes should continue to stay the way they are in the mechanical piece of it?
Well, I think that it's incumbent upon the department, Medicaid, to continue to do that analysis to determine the value of health homes and put forth any recommendations. I will continue to move forward in making changes in the structure of the health homes as we move forward the next few months. For example, the state plan amendments, we need to amend those, align those. We also need to make sure that providers are complying with the state plan amendment, because eventually the Center for Medicare and Medicaid Services will come in and look at that as well. So we have to make sure that we mitigate any of that risk. We also have to set clear expectations on what those health outcomes are, not just looking at cost. So yes, I think also as far as from a data perspective, one of the first things I said, we're not collecting the data we need to. There are 6 core services in health home. I couldn't tell you without going into the clinical review of that record what that core service was provided. We need to collect that through the encounter data process, and we're moving forward in doing that as well. So we're actually getting a little detail here. We'll be assigning a CPT code for each one of those core services, so that as that claim is submitted to the MCO and the encounter comes to us, we know exactly what service was provided to the individual. We'll still go out and do clinical reviews of the records, but we just need to do some of those things as we move forward.
I would strongly, as a member of this oversight committee, I would strongly ask you to take into consideration what the providers are presenting to you as much as maybe the MCOs would be presenting to you. I know that there was a dust-up about United Healthcare wanting to take over the health homes piece of this, and before that decision is made, I hope that you would work with the providers to make sure, just like what you said, to set up guidelines to see if they can meet the performance that is the expectation that you have, and we all have for that, before you make a sweeping change and take it away from them.
No, absolutely, and I think that part of what is in that report as well, one of the things that I said early on I was concerned about was duplication of services, and that's relative to care coordination. So we have to clearly understand who will be providing that care coordination, whether it's working with the providers and working with the MCOs, working with integrated health homes. We just have to make sure that that service is not being duplicated across those entities. Because again, we have to assert our state plan amendment that we are doing what we can to ensure those services are not being duplicated. So that's just one of the components. But absolutely we'll work with the provider work group as we move forward in MCOs. So there'll be no sweeping changes without transparency with the providers and communication and working with them. They might not always like the direction we're going, but at least we'll have those meetings and we'll understand their concerns and we'll move forward.
All right, thank you.
Okay, Representative Forbes.
Thank you, Mr. Chair. You just kind of alluded to this, but you say there should be additional analysis being done on integrated health homes to make sure that things are going properly. And you mentioned that you're willing to work with providers to make sure that things move smoothly forward and not really make any changes until we see this report fully investigated and vetted well. So change-wise, do you see any changes coming before you get this total analysis done?
Well, I think there'll be some changes structurally or state plan amendments, or as I said earlier, requiring CPT codes, which is the core services. So yeah, those changes will occur. But I think it's going to take some time for us to do that detailed data analytics relative to the value that we're providing, or is it not? Because we'll have to go into the clinical records, we'll have to go into the encounter data. So it's just a process where we're going to dig deeper into that data. But we will continue to work with the providers as we move forward with this.
And you said you worked with about 20 different providers on this work group.
I believe there are about 20.
So I assume there's better players than others when they're providing services to these patients. Did you see that from your
I think
study?
there were indications that some providers were providing, I don't want to say greater value, but their outcomes appear to be better than other providers. Mm-hmm. But I think it's an opportunity also, we need to understand why that is. Correct. Because it could go back to your point earlier as far as lack of training, understanding, and we didn't see that. And it's not a bad thing. I mean, we need to take responsibility for the rollout and the implementation of health homes. I don't know if the state did a good enough job in doing that. Mm-hmm. I don't know if we did a good enough job of holding the MCOs accountable, because there's very specific language on what they're required to do from a health home perspective, and not just integrated health home, but chronic condition. Mm-hmm. So we need to understand why that performance not be where it needs to be. Perhaps we didn't clearly articulate those expectations.
Well, it's important we deliver consistent services throughout the whole program throughout the whole state. So, the other question I have is, you had the 8% that received no services. Is the reason because people just kind of drop off the map, or is it the providers aren't really doing a good job of working with them? Or how can we improve that number, I guess?
I think it's a combination, and that 8% is because it was a random sample, and that's something else. Even though it was statistically sound, I think we need to look at additional, maybe targeted health homes to understand the performance and not just rely upon that statistical random sampling. Mm-hmm. So whether that's 8% or whether the number might be, I think we just need to understand exactly for those particular providers, maybe going in and understanding, it could just be a miscommunication, misunderstanding of what that PMPM is for. It clearly could be that. So that's why it's clearly going to be articulated that you must provide a service to get a PMPM. You must submit that CPT code to get reimbursed, and that's going to trigger that. And that does a few things. It allows us to see what services are being provided, and we can better track that. Mm-hmm.
So if a person doesn't provide any service, they don't have any services, say in the month of December, but they do in January coming up, they'll not get paid for the December, but they will get paid in January.
Correct.
If they show there's some type of activity.
If they provide one of those 6 core services, the intent is to reimburse that per member per month.
And currently, right now, they're getting paid regardless, correct?
It's not clear. That's why we have to be much more clear within the state plan amendment. Okay. And so that process is going to take some time, because literally I want to make sure we work with providers, because they have system configuration that they'll have to deal with. Mm-hmm. The MCOs will have system configuration. So this is not something I can go over to the wall and turn the switch on. Yeah, it's going to take some time, but we want to do it right.
Yeah. Well, I just got the impression from the original report here that providers were getting paid for that 8% that were receiving service.
Yes.
They are right now.
That study.
So we're going to
during that study, we are going to correct.
We're going to correct that part. Okay. All right. Thank you.
Okay. See no further questions. So let's go on to the next section of the level here.
Okay, I'll just give you a quick kind of high-level overview on level of care issues, and then Director Randall can take it from there again specifically. We looked at the data from fiscal year 17 and 18 for the MCOs members who are receiving waiver services. The Iowa Administrative Code says that level of care reassessments are to be completed at least once annually, as well as whenever the member's condition changes such that they may need to change their level of care. If it's determined that a level of care change is necessary, the MCO or whoever's requesting would have to submit documentation to IME to us, and we ultimately make the final reassessment determination. The Quality Improvement Organization from IME completes all the initial level of care determinations and reassessment requests that are submitted. And we of course use national best practices when completing level of care reviews to ensure that the appropriately medically necessary services are provided to meet the member's needs. And so that's kind of an overview of just how the reassessments work. If there is a request for reassessment, it always comes through us. We always have the final say about that. But I'll turn it over to Mike to give you more detail on that.
Again, there was a report submitted on Friday. It's a 7-page report. It gives all the detail, much more detail I'm going to go through here at a higher level. But for state fiscal year 17 and 18, there were 6,069 review determinations for MCO members seeking LOC or level of care eligibility in the waiver program. Of those, about 98% were initial determinations. Obviously, the 2% or 132 were reassessment requests. There were 3,590 for state fiscal year 17 and 2,479 for state fiscal year 18. The breakdown of the reassessments, 132 reassessments by waiver, the HD waiver, 35%, elderly, 24%, IDs, 22%, children's mental health, 13%, and the PD and the BI waiver were 3% respectively. The MCOs requested reassessments for obviously higher level of care, lower level of care, and really to deny the level of care. IME approved 31 reassessment requests for higher or lower change in level of care, and they denied 26. Looking at the findings, less than 1% of reassessment requests were received from each MCO individually, and that really only combined for 2%. So very low requests for reassessments. The MCOs, looking at 17 and some of the trends from the report, take a look at the MCOs were submitting requests for a higher level of care for members whose care needs exceeded that per member capitation rate. So remember, in the Iowa Administrative Code, there's a cap rate for every one of those waivers. And so those level of care changes are being requested to exceed that. That was one of the trends we were seeing. IME determined members may require multiple services. However, those services and treatments and care needs did not meet the Iowa Administrative Code requirements to approve a higher level. So there again, it didn't meet the Iowa Administrative Code. We also provided guidance to the MCOs indicating that we were seeing those trends, so you're starting to see that go down somewhat in state fiscal year 18. Again, there is a much more detailed report, graphs that you can see of the information I just shared. So with that, Mr. Chairman, I'll pause and answer questions.
Okay, so one thing that I have noticed, that I noticed in what your statements there, you said that, I think you said that some people needed a higher level of care, but the Iowa Code didn't allow for that. So how do we handle that, and is there something wrong with the code, or what?
Well, it really depends on the particular waiver, but you could go in and whatever the circumstance was, you could go in and review the Iowa Administrative Code. That is correct. But one thing I've always stated, and I'll state again, is, as Director Foxhoven has mentioned as well, had the same issue with the tiers 1 through 6, and those members kind of fell out. If I get an exception to policy that needs to exceed that, then I'll do that review. I may go visit that member, and I'll approve that exception to policy. Would I rather have something different in code? Probably, but I'm not going to let a member not get their needed services just because Iowa Administrative Code limits a particular waiver to $3,013.08.
Okay, thank you. I just wanted to understand how that was handled. Joel, represent Friday.
Thank you, Mr. Chair, and thank you, gentlemen, for being here today. As I was looking at your report, one of the things that I think might be helpful for us all to hear from from you on is in relationship to each individual MCO and the data that you found specific to each MCO. Could you walk us through a little bit more detail of that?
Just bear with me here, I'm trying to find, do you have a particular page? So I am, for your reference, I know you have it in front of you, page 7, we're right below, or right above the summary. I'm going to focus on state fiscal year 17 and 18. So AmeriHealth, obviously they're not in the market at this point. 9 reassessment requests. Our QIO approved 6, denied 1 of those. QIO approved unspecified level of care change request 2, and it denied 0 for ACIA. For I'm sorry.
Turn your mic on.
Oh, thank you. No, that's all right. Goodness, I thought my voice carried. You can hear you, but they can't hear me. Well, the important people heard me.
Which are the legislators.
The legislators is what I'm referring to, Director Fox. So when United AmeriGroup, there were state fiscal year 17, 20 reassessment requests, 9 approved, 9 denied, and 2 denied for unspecified change request. Taking a look at United Healthcare, there were 10 reassessment requests, 5 approved, 4 denied, 1 unspecified request approved. Would you like me to go to state fiscal year 18 as well?
No. Well, can you talk to us about any trending that you saw in those numbers? Did you see specific things as to why?
I think the specifics, kind of like I alluded to earlier, is the sense that they were requesting those level of care changes. I don't think they quite. I mean, it's early on. You got state fiscal year 17, especially. Probably not completely understanding the Iowa Administrative Code.
Okay, I see no further questions. So we're about a half an hour, or what are we? Yeah, about a half an hour ahead of schedule, but I'm okay with that because I need to leave at 10 for caucus for a little bit anyway. So if we could, let's just go ahead with the process improvement work group.
Okay, again, I can give you kind of a high overview, and then Director Randall will talk specifically here. When I came on as Director of the Department of Human Services, I obviously recognized pretty quickly we had a lot of problems that needed to be fixed with managed care. And as I brought on Director Randall, the first thing I said to him was, we need to figure out what the problems are for the providers. Hear from those providers, find out what the problem is, and let's get on with fixing them right away. Mike said, let's create a process improvement group where we bring in the providers and really just roll up our sleeves and say, what are all the problems that are here and how do we fix them? Sees it as kind of a long-term thing that we grab on the most important things right away and then continue to work with that group to figure out where do we need to go. The first meeting was in February of this year. And sat down for about 3 hours with the entire group to figure out what are the issues that they think were most important. They identified 150 of them. Needless to say, we haven't solved all 150 of those issues in those few months since then, but we have made a lot of progress, and I'll kind of turn it over to Mike to show how he's prioritized what the providers and the MCO saw as the most important problems that they were experiencing and how we could address those and what we've done so far.
Thank you, Director Fox. I was just reaching for that microphone. Again, yes, we first met in February of 2018. I think there were 75 or 80 providers in that room, and we specifically chose certain providers, those that had some significant issues, concerns, those that had been very vocal, candidly, but I wanted to hear from those providers because I knew they wouldn't be shy in sharing what their concerns were, so that's why we did that. We did spend those 3 hours. We actually sat in that room for about 3 hours. I facilitated. Many of those 150 issues were duplicates. A lot of it, and that's kind of where we formed themes. But they spent 3 hours, and we wrote down every issue, and we captured everyone on index cards. We captured those in a spreadsheet. All of this information going all the way back to February is on our website. So you have all the minutes, you have the agenda, you have the documentation. It's all out there on the website. It can be reviewed by any provider, any individual, any member. So we took those issues submitted and we organized them basically into 8 really common themes. And at the following meeting, we split those into 4 subgroups because we needed to, kind of make that more manageable. So you're taking a look at, provider credentialing was one. Taking a look at appeals and grievances, prior authorizations, taking a look at member benefits. So we met, the subgroups have been meeting, I think, monthly since that time. We'll continue to have discussions with the group. I don't know if we'll continue to call it process improvement working group. It'll transition to some type of group, but we will continue to have that feedback from the providers, and we'll meet on a periodic basis with the MCOs, with IME, and with the providers. And I think it's important to note too that at these meetings, I attended every one of them, the MCOs attended every one of them, and not just, the plan presidents were there, chief operating officers, the CFOs. I wanted people at that meeting who could make those decisions and clearly understand what those issues were for those providers. So I think that is where the success, and we'll continue to move forward with that as well. Some of the findings, as I said earlier, is a dedicated DHS website to follow the group's work, the agendas, the meetings, the work plans. Any decisions made by the department appear there as well. Some of the common themes, need for additional training and clarification. As we started working through, especially the credentialing, it really evolved more from credentialing to rosters. We didn't realize that. We couldn't get that information until we started having those meetings and those discussions. And so there still were some challenges with credentialing, some timeline issues. So one of the things we've done in the contract for the new year is we've kind of specifically outlined those timelines for credentialing and when the clock starts, so to speak, because that was a question. When does the clock actually start? Well, we'll learn to define that for you. So we have that specific language in there as well. There were 2 different processes for the same thing. So right now we'll be bringing in a 3rd MCO as well. But to the extent possible, can we consolidate some of those processes and make them the same? So we're continuing to discuss those. There were some that we have basically collapsed, and the MCOs will be doing that. Credentialing is one of those as far as the form. Improved communication was extremely evident as well. I think that one of the things that came out of those meetings, it's really, especially from a claims or billing perspective, and Representative Forbes, you can understand this, there's a lot of turnover in that particular group. So you can't have training once a year as far as what needs to be done. So we're implementing, and the first quarterly training will be sometime early this spring. But that training is going to be focused on what the providers want. So we've done surveys. We sent those surveys out. We've got those surveys back. And so we will tailor those training sessions with the MCOs, with IME there, and with the providers based on what they want. And we'll do that throughout the state in several different locations. So we're moving forward and scheduling that and getting the logistics done at that point right now. As far as next steps, we're going to, as I said, implement the quarterly training. We received more than 700 responses from that survey, which I thought was very good as far as what we want to train on. They collaborated, the MCOs, to better streamline several processes. As I said, provider credentialing, appeals and grievances, prior authorizations is one as well. We will continue to do that on a periodic basis. Just some information for you. My team and I meet with the MCOs once a month. We have a joint meeting with the MCOs, and we have an individual meeting with each of the MCOs. I'm present at those meetings. My leadership are present at those meetings. The plan presidents and their leadership teams are present at those meetings. And I implemented that several months ago because that, I think, is an important way to get some issues resolved right then. You have all the decision makers right there in the room. You can establish timelines, establish project plans, whatever the case might be on the issue, and hold them accountable. They can hold us accountable. And I think that's been successful, too, as we move forward with kind of doing some of the things in this program that we need to change. Communication, I talked about improved communications. The MCOs really did provide information on how to escalate issues. So you can go out on the website, see, especially from a care coordination perspective, regional contacts that if they're not getting information they need, they can escalate to this particular individual. So that's out there. MCOs provided detailed information regarding case management, non-emergency transportation, how rates are loaded in their respective systems. So whatever the issue was, we went through very meticulously the issue, identified recommendations to change, and moved forward with those changes. As I said, we will continue to work with the MCOs on review of prior authorizations. That will be continuous. I think that part of the, not that it's the all and be all end all number, but we track prior authorizations, and so we know that, you know, it's, you say 90% of the time those prior authorizations are approved, and we need to sit back and ask ourselves, why are we having a prior authorization? There may be a legitimate reason to have that, but if you're approving those 90-95% of the time, can we eliminate those? And if we do eliminate, when we have eliminated a few, if we do eliminate prior authorizations, it's across all MCOs and IME. So we're not going to have prior authorizations just for Iowa Medicaid. The 3 MCOs won't have that. It's consistent across the entire Medicaid program. And one final note, and I'll be happy to answer questions. Iowa Total Care, any decisions or any processes we implement, they also will be required to do that when they come on board July 1st of 2019.
You know, perhaps before we get to questions on that, I just wanted to just say one last thing, and that is I went to the very first meeting of the Process Improvement Group, and basically I told them, you're here because you've made the most noise, you've complained the most, and we're least happy. And, you know, I'm pretty proud of the fact that we did not just pick out people who were happy. I mean, you may not hear it in the news, but we have plenty of providers that are saying, we're really happy with how things are going. They weren't really included in the process improvement because it was working for them. So what we really did was we affirmatively reached out to people who said, we're really not happy with how this is working. And so some of them kind of laughed when I said, you're here because you complained the most. But the bottom line is that's how we fix problems, is find out where the problems come from. And it would have been easy from Director Randall's standpoint just to bring all the people who were cheerleaders who said, yeah, everything's going great, put them together, come back and report to you, nothing's wrong, everything's going well. That would have been fine from a publicity standpoint, but not from fixing the system. And the reason the system continues to work better and better is because we're open to the people who really were not happy, try to figure out what it's going to take to make them happy. So, we'll go to questions now.
Okay, Representative Fry.
Thank you, Mr. Chair. Thank you again for this report. And you both know it's been important for Representative Heath and I to discuss this prior authorization and the credentialing issue that continued to circle around. You, Director Randall, mentioned that you did eliminate some prior authorizations. Do you have a list of which ones you did eliminate?
I can get those for you.
That'd be excellent.
I did ask for them, but I unfortunately wasn't able to get them.
Okay, my hope when I see that list is that I see especially providers like hospice care, those situations where it's pointless in the situation, medical care-wise, to be asking for prior auths. I'm hoping I see some of those sorts of providers on the list. Thank you.
So, I might ask about the same one. I've heard of a situation where I maybe shouldn't be asking specifics, but this was in my mind, so I'm going to bring it up. Someone who has a drug substance abuse problem, and they're in there and they need some type of medication, and then if they have to wait, they're just going to leave, and then it's caused problems.
That's a great question. I know exactly what you're talking about, Suboxone. And the problem is right now that the federal government requires pre-authorization for that. So we're trying to work with the federal government to see if we can change their position on that. I think we totally relate to the fact somebody comes in for treatment, heroin addiction, is ready for treatment, to say, well, we have to wait and get approval for that drug. But right now the federal government requires us to do that. So we're trying to do two things. One is to work through a quicker process. Any kind of process that slows it down at all is problematic for someone who's got, you know, a severe addiction problem. And then secondly, we're trying to work with the federal government to see if they can waive that requirement or at least somehow modify it so that we could at least approve some right away and then move forward.
Thank you. Representative Forbes.
Well, to go along with that, you know, there in the prescription drug program, there is a 3-day kind of emergency fill that can be utilized in that case. Now, I don't know if it's taking more than 3 days, but we sometimes will have to use that to make sure we get the care to the patient in cases with Suboxone, which is highly controlled and in some cases very expensive medication. So, but there is that available.
Yeah, I think the reason that providers are concerned because someone comes in with an addiction problem and even waiting 3 days, they're probably going back and so we're trying to figure out a solution to that.
Yeah, well, and I don't, after the 3 days, I know that becomes a problem if it's not approved. But there is that little bit of a safety net in there to help through that first 3-day period. The other question I was going to ask too is on prior authorizations for prescription medications. Do you have any statistics or numbers on that? What % of medications are approved or not approved on prior auths?
We do. I don't have it with me, but we can certainly get the information.
Okay, I'd just like to be able to look at that and see what that number is. In our previous meeting, you had mentioned that we were going to, you were going to go to a calendar year for contracting with MCOs. Can you kind of update us on the progress of that and where we're at? And the thing we talked about last time, it helps us in our budgeting process. So we'll know the number before we get out of here in April or May. If that's going to be this year or next year. Or...
No, my goal is to have that information to the legislature in early January. We have been meeting with the actuary, and we actually have a meeting with the MCOs this Wednesday to walk through draft rates and begin that discussion. So clearly, in moving to calendar year, the primary purpose was so that we could provide that transparency to the legislature. Obviously, if it's fiscal year, and other states have struggled with that as well, it's very difficult to get that finalized draft rate and amendment signed prior to the legislature leaving. So the only way really to do that, as I told Director Foxhoven, was we need to move to a calendar year. It does a couple other things for us too. It provides some administrative simplicity, both for IME, for the MCOs, for providers. It just makes much more sense from a calendar year perspective. So we'll be doing that January of 2019. So we have, like I said, we have been working with the actuary for the last 2.5 months, and very confident that sometime in January the legislature will have here are the contracts.
Okay. Then my last question is, we talked about it, some providers, were happy, but have you guys done a kind of a broad range survey of providers to kind of get their feel, just to show us as legislators how it really is going out in the field? I mean, I'm sure we got people that are very happy, and we hear of the people most of the time they're not very happy. But it'd be kind of nice to know, is generally speaking, are providers happy with the way the program is set up and running?
We do have surveys with our EQRO. It's not the type of survey I really want to do, so I'm trying to work with them. I had that very question several months ago as we move forward. So I do want to survey the provider community, and I want to make sure that it's broad-based. So it's not just surveying the long-term care nursing homes, it's not surveying LTSS providers, it's not just surveying pharmacists, but we have 40,000 plus providers, give or take a few, in this state. So what's the random sample I need to at least get a good response rate and have some confidence that when they return the survey, I can kind of believe what was in that survey. Mm-hmm. So we're going to do that, yes.
Okay, that's all.
Representative, I guess Senator Mathis, you have your hand up first.
Okay, thank you. I'll make this short, Representative.
When you were with this group, and you said there were several people selected, I'm assuming that there were hospital people on the, I haven't looked at the list of people that were on there. What did they say about prior auth and people who were coming in through the emergency rooms? Did they have complaints about that and the difference between prior auth and observation and admits? So what was the conversation around that?
Honestly, I don't recall a conversation relative to that from the hospitals. They could have mentioned it, but it didn't surface to the point where it was a big issue. I think that there were other concerns that the hospitals had relative to reimbursement rates and some of those other things and DRGs, but I do not recall specifically that coming to the surface.
Okay, because and this was about a year ago. They were saying that that people were kind of saying, "Oh, look, admits are down." Well, the hospitals were telling us admits were down because there were arguments over pre-auth. So they couldn't get pre-auth, and the MCOs would say, we're just going to put that patient on observation, and maybe after the hospital had absorbed all the costs for 3 days of holding that person and not getting pre-auth, a prior authorization, then the MCOs would say, no, we're not going to give it to you. So what do you do with a patient who's been there for 3 days, coming in through the ER, and the hospitals were having to absorb that cost of taking care of that patient without any payment? So I just wondered if that was still an issue, and they didn't bring any of that up.
Again, candidly, it's not risen to my level. I'm not familiar and have not heard that.
Representative Heath? Yeah, just to continue on the emergency room issue, I got a lot of comments from the University of Iowa hospitals on this issue. The air ambulance comes up on the roof, they drop them in, they do all their stabilization and whatever. And then they move them from maybe the ICU on through the process. They're not going home, they're going to stay there for a while. And then there's this issue of prior authorization, where they have to have people on their staff just to deal with the prior authorization, a medical person, a full-fledged doctor, because they have to ask for it and defend their request. It's just, I can understand the MCO wanting to be able to keep track of just what's going on. I understand. But there's some hiccups in the process, I think, Director Randall, that you need to kind of walk into and see if you can smooth it out.
I'll certainly be happy to look at that. I have a monthly meeting with the University of Iowa. I can certainly ask them that specific question, and they can give me some specifics, as well as reach out to a couple of other large hospitals.
So even though, I'm speaking from a Medicaid point of view, and attending the meeting we had in Iowa City, the university is also, regular insurance companies now are also intervening and starting to direct the care of the patient rather than letting the doctors direct the care to the patient. And it's a culture. I mean, there's a change coming here, and I think we need to get a handle on this before it's out of control.
I appreciate you mentioning that, because it's not just Medicaid, it's obviously Medicare and commercial as well.
That's correct. So one of the things that I always got some emails on is the transportation issue. Not necessarily, well, it was just nursing homes and people out there who are in rural towns who need transportation. And then the MCOs contract with somebody to provide that transportation. It's the quality of transportation that would be available. In other words, a person might need to have a vehicle to handle a handicapped person, but they pull up in a four-door sedan. It doesn't work. Poor quality cars, whatever. It's just down on the front end of this thing, there was a big inconsistency. Now, I haven't had any calls here for the last month and a half on this issue, but, I can understand you meeting with the MCOs and everything, but what's really happening, I think you need to be communicating with your providers, so like you were, and maybe continue to do, to try to get some feedback of how this is all playing out on the front end.
Go ahead.
And we do have continue to have conversations. We had Mickey Steer and I last had conversation on Friday with the provider on that regard, kind of following up with what can we do to improve that situation. So I mean, there's no question that it has come to our attention. We're trying to resolve it, trying to improve that.
And that's one of the topics that did come at the process improvement working group, and the MCOs will come back and provide very specific data on non-emergency medical transportation. That's something we continue to track.
Just one more thing. In looking at our system now that we have with managed care, all I'm asking for is to try to continue to promote the operation of that system more smoothly. We're moving into a lot of new things in mental health. And we don't need all of a sudden difficulty in providing adequate services to these people who desperately need them. I don't need a managed care company creating a lot of issues. We're trying to deal with opioids and trying to deal with substance abuse in a rural setting. We're trying to connect telehealth with those substance abuse providers so that we can use adequate drugs. And we just, in order to move forward in some of these exciting new things that we're going to do, you know, I get concerned sometimes when all of a sudden I hear, well, yeah, but we can't get the treatment, or we are involved in prior authorization. It's bumpy, Representative Eaton, and it's not good for the patient. You get what I mean?
I do, Representative Eaton, and I just want to say, I think across the board people would say, if you compared where we are today to where we were 2 years ago, it's hardly believable that it's the same system. There are lots fewer complaints and problems. Any complaints or problems or issues that we want to resolve, we want to fix it. So we're going to continue to try to improve it, but it's a much smoother system than it was even just a year ago.
Okay, Senator Reagan.
So, Director Randall, have you had any prior authorization concerns on supportive employment rise to your level?
No, ma'am.
They have not?
No, ma'am.
I would just be concerned that maybe there would be some job loss in between waiting for prior authorization.
Certainly ask the question, but no, not to my desk. I've not seen it.
Okay. Okay. So that opens, one last question. On this new memorandum that I read from, you went to a Medicaid conference, National Medicaid Conference, and Mr. Azar made an address to you people. Did you go to that?
Are we talking about the pharmaceutical summit that the National Government Association had last week?
No. It was before that. They started to talk about a lot of the things that they want to open up Medicaid to be able to provide.
Correct. It was the National Association of Medicaid Directors Fall Conference.
Were
Correct.
you there?
I was.
Okay, so when you got the report and you looked at all the new things that they say they might entertain to take care of, for instance, institutional care, there were other things in there that I thought were very exciting. And I look at managed care, and I look at this whole situation. Are you entertaining any of these suggestions to put in into a state plan amendment to incorporate what they say they would take care of?
Obviously, we're looking at a lot of what was in that report. So SUD waiver, IMD exclusion, and some of those various things that were in there. There were some children's health initiatives that are in there as well. And, you know, we get those reports and we get those communications as state Medicaid directors all the time. And so we do review that and we do an evaluation. If it makes sense, we could potentially move forward with something in that. One of the things I always have to balance are resources. It's unfortunate, but there are a lot of great things out there. You're exactly right. And so we need to balance what makes best sense for the state of Iowa and what's the greatest need in the state of Iowa and move forward with those, because we simply can't move forward with all of them.
I think it's important that maybe, I'm going home, but I think it's important that maybe next year in this coming session that you bring that piece to the legislature and talk to them about some of the things that the feds are willing to do to make and to improve our system. Associate some costs, ask them if they would want to come up with the money, whatever. But I think it's important that our people on the policy committee and the appropriation committee, human services, are aware of what is in that report, because it is really, I couldn't believe some of the things that all of a sudden they want to get involved in.
I think
All we
that's
have to do is ask.
That's a great suggestion, and what I think I would probably recommend, and I know Kevin will write this down, I'm not gonna have to look back over my shoulder and ask him to do it, is that at some point, either during budget hearing or some of the other policy meetings that we might have, to give an update to the legislators on the federal landscape, you know, what's going on. And that, I'd be more than happy to do that.
Okay, seeing no further questions, we are quite a bit ahead of schedule. I wanted to mention that for the public comment time, we have a sign-up sheet back there. I think we currently have maybe 3 people signed up, but I think maybe we'll limit that to 5 minutes. So you plan your comments, try and limit them to 5 minutes so everyone gets a chance. So just with the permission of the committee, I don't see any reason why we shouldn't go ahead and start with the July transition to information rather than take the breakdown. Okay?
Oh, that's fine with me. That's absolutely fine.
See, warmed up.
So, briefly talked about it last time, but you know, the department, we meet with Iowa Total Care about 8 times per week. And we've done that since October 1st, about 80 meetings. We have an IT session meeting every week. We have 6 subject matter session meetings every week. 1 overall project update meeting every week. They've additionally been included in those ongoing MCO meetings that I mentioned earlier, where we meet with the MCOs on a monthly basis. Once we've signed a contract, we've invited that plan president or interim plan president to participate in his team leadership. So they do that as well. Some of the topics for subject matter sessions include all policy and functional areas. So I'll go through a few: LDSS, HCBS, community and facility. We'll talk about behavioral health, hospital, therapy, pharmacy, network adequacy, provider enrollment, case management, value-based purchasing, claims payment, provider rates, member eligibility, and the list goes on. We will continue to occur, those meetings will continue to occur into January. Additional meetings will be scheduled if we see gaps in knowledge or discovered through some of the follow-up questions. The readiness review will begin, those activities from a desk review perspective will begin in February, and we'll have on-site readiness reviews in April. So we're confident as we move forward with the July 1st implementation for Iowa Total Care. As I mentioned before previously too, we will have open enrollment in March. We have tried to mitigate as much as possible the disruption to the members, so we have excluded members from that auto-assign, that algorithm. It's about 130 to 140,000. I have the exact number in front of me. For example, pregnant women, those with serious illness and have those established relationships, we're not going to disrupt them. They will have the choice, though, to change. As I said, those will go out sometime in March, and then will be effective July 1st, and they will have another 90 days in which to choose the assignment for the 3 MCOs. I'll be happy to answer questions.
Okay, so I have heard concerns of some people saying that, oh, this person can't stand any more changes, and so I'm encouraging you that you have that 120,000 group or whatever, I mean, that group of people that are not going to be assigned.
Plus, they always have choice, and so they can say, no, I want to stay where I'm at. And so that's really not an issue there.
Okay, so just for my information on the numbers, what percentage of the patients are we, or members are we anticipating to move to total care?
There will be, what we've done, because I want to make sure we don't repeat history, is we want to kind of set a minimum percentage of population, and we also want to set a maximum percentage of population. So I didn't want, for example, one MCO to have 75 or 80% of the long-term support services population, or 80% of the long-term care. So there's a minimum of 25%. There's a maximum of 55% by population, and overall, 45%.
I think that's all the questions I have. Representative Head.
Thank you, Mr. Chair. My question's along the same line as Senator Costello. I've had a number of families who can't handle another change. They've been through, well, I don't know, I think I'm on my 6th case manager, so they don't want to do that as well. But my question is, when we first went to managed care, there was a lot of education out to individuals so that they were aware of, you know, what was managed care, who were the 3 providers, and stuff. So can you tell me a little bit, I know that the enrollment's going to happen in March, but what additional education are you doing out for folks since we do have a new entity coming in? Again, I understand where you're saying people can stay with their current provider. People are going to get confused by it, and it's going to stress the family member out and the individual out as well, with potentially them being the ones that's getting changed to somebody else.
There's 2 things. Their enrollment package will contain a lot of information, and I know that, you know, just like myself and perhaps you, if I get a package in the mail that has all this documentation, sometimes I'm just going to kind of put that over here in that little trash can, and I'm not going to pay attention to that even though I should. So, but that will be, the information will be there, but we're also planning on, and don't have the timeline, going out and having what I call stakeholder meetings and kind of walking them through the process, walking them through, you know, here's what you expect to receive, here's what you may have already received, here are your options, here are the 3 MCOs, just having worked through all the logistics and details of that, but there will be that communication as we go out across the state and just having identified where that may occur.
And just on that, so has Iowa Total Care built up their provider network? Because that's going to be the other consideration for folks, is to make sure they can maintain the same physician or therapist that they're going to.
And that's one of the meetings we have every week. And yes, they are actively going out and negotiating contracts with providers. I think once the contract was signed with us, they were able to do that. So they are aggressively going out and recruiting and contracting with providers.
Thank you. Thank you, Mr. Chair.
Representative Forbes.
Thank you, Mr. Chair. I don't know if this is really related to that, but I met with a constituent last week whose son is a dual eligible Medicaid patient, and she was telling me that she's been called 3 times by, and I'm not sure who was calling them, but I think it was from one of the MCOs, I think, and asking them to switch to a Medicare Advantage plan, and they would then be eligible to get $1,000 worth of free services. And this was kind of confusing the person because they got 3 different calls from 3 different people.
Same entity?
I'm not sure. I don't have a lot of detail, but are people getting called by somebody asking them to switch, if it's a dual eligible, that they would be switching to a Medicare Advantage plan?
I'm not aware of that, but I'd be happy if you have a particular name of the individual that you could share, or...
Yeah, I can do that. I just was kind of confused, and then they were offering $1,000 worth of products or services from a...
United Healthcare.
It is United?
Yeah.
Well, can you explain, somebody needs to explain this to me, because I don't know why they're out trying to call these individuals, try to get them to switch.
We'll follow.
But you're aware of it too?
Mm-hmm.
Well, we'll follow up.
Because I think it's confusing to the people.
I can understand that.
When they get these calls and, you know, I just thought, well, that's kind of strange because, you know, our Medicare Advantage plan is now to do all
Representative Keaton.
Yeah, in carrying on with what the 2 have been talking about, I was at an NACL convention this last summer, and there was discussion about one of the major insurance companies, which also is in managed care in our state, who are coming forward with a dual eligible policy. It's kind of there's a pilot going on somewhere dealing with dual eligibles and insurance. And I was very confused, and so if that be the case, somebody maybe needs to to call the insurance commissioner and ask him what's going on. Because I think if you're Medicaid, you're gonna wanna know. But I understand that one of our managed care companies is coming forward with a dual eligible policy.
Well, let me make sure everyone understands too, and I'm not a Medicare expert, dual eligible, there are only certain things that Medicaid pays for, so they are Medicare. And I think that there are plans out there, whether it's an insurance company in this state or others, there are those Medicare plans for those members. And as far as I know, there's nothing that prevents that entity from marketing a particular Medicare plan to a Medicare member. Now, if they kind of dip into the Medicaid side and start doing some things, and that's when we have to start having questions. So I just want to make sure, and again, I'm not the expert in Medicare, but I do know that that is something that can happen.
Representative Lumber.
Thank you, Mr. Chair, and thank you for your information that you're sharing with us today. I don't know if it was last year or maybe the year before in one of our budget sub-meetings, I mentioned communication being a big issue when it came to our original rollout. And I think we all get many calls with people that are very confused about the documentation and information they're getting. And sometimes they get it from more than one MCO, which really adds to the confusion, I think. So I would just encourage to keep it as simple as possible. I mean, we all probably receive phone calls from people that get 1 or 2 packets from one of the MCOs asking us, what do I do with this information? And we look at it, and we look at it all the time, and it's confusing. So just going back to keeping it as simple as possible as we're giving these explanations to people. And you're right, the packet, we all get them. We get them from our insurance companies too, and we set it aside. But you know, we're dealing with a population of especially in our vulnerable families, that just aren't going to grasp the data and information that's being given to them. So I would just continue to encourage to keep it as simple as possible.
I'd like to add to that, Representative. I can remember, it wasn't really a rollout. We just, one of our managed care companies exited the state, and all of a sudden, a lot of people were switched over, and there was a lot of concern when it came to the case managers. And I was getting reports of case managers contacting their patients or their clients by telephone rather than face-to-face. Case manager this week, a different one the next week. I just hope that when this new company comes on board, that they have adequate staff and adequate case management so that there is not this confusion when they maybe switch companies and go with it. It was not pretty when the one company exited and all of a sudden there was a lot of change, and that case manager is so important to those clients, especially vulnerable families. They depend on that person, and it gets to be almost a personal relationship. They trust each other so much. So
Sure, and I would just say those are lessons learned that we've learned from that. I would also say that we really, for a remarkable short period of time, did a pretty good job of that transition. Some people may not feel like it, but we had very little notice, and it was really virtually seamless. United at that time took a lot of those members over and actually hired most of the caseworkers that was at AmeriHealth to make sure and assigned them to the same people they had. So while there were some that did get disruption, they really minimized it as much as I think was humanly possible. And so they did a really good job of trying to prevent some of that damage. And again, the fact that the change in the transition, we've tried to take the most dependent members and not make them part of the change. It will hopefully minimize that.
So there's going to be a reshuffling again of, because they're going to be hiring people probably from United and America. There's going to be a reshuffling. Is there, I guess, I'm thinking about the caseworkers and them communicating with their members. Like, well, I'm going to go to the new one. Is that acceptable for them to tell their members that they're moving? And maybe I guess I wanted to see how that would be something that, let's say, you know, your member is attached to their worker and then they switch to a different company. Is that, how's that?
Well, they can't ethically go to them and say, hey, you ought to switch to this company because I'm going there. Obviously, as Representative Heaton said, they have relationships. They're going to say, I'm leaving. They're going to ask, where are you going? They're going to say where they're going. And so, yeah, they're going to, I'm sure, know about it.
Just recall, the member always has a choice.
Yeah.
90 days before, 90 days after.
Right, and in this whole process, we want to keep in mind that the member is the one we're serving. So.
Absolutely.
Absolutely. And when that transition occurred, I remember one member calling me up and saying, I lost my caseworker, it's going to be awful. And I said, gee, this was when we were in the middle of transition. And I said, gee, you know, I checked and United hired the caseworker. And the woman said, well, she retired. I said, well, I can't stop her from retiring, you know. And so, I mean, sometimes things just happen like that, you know, where people will retire and that's going to be a disruption. And I know it, to the member, that's as much disruption as if they just got laid off. But the bottom line is some things we just can't.
And I think that's key as we go out and have these stakeholder meetings and provide education relative to this transition, is that they always understand choice, and this is what your choices are. And we'll do the best we can to ensure that we are effective in that communication.
Senator Sagan.
Thank you, Mr. Chair and chairs.
About 6 years ago, when I first became a legislator, a good friend of mine who runs a nursing home thought it was important for me to see how thick the application was to become Medicaid eligible. So she brought a big, kind of like what we send out, a big yellow manila envelope, about that thick, of just all the forms that had to be sent in, which usually took about 30 days to get that form complete, and then another 30 days after you send it in to get the qualification. So my question for you, Director Randall, is, if director is the appropriate name here, you're supreme leader. But if you're, 25% is going to Iowa Total Care, were they assigned this time, or are they just made aware or given a choice? And if they're given the choice and they decide to go somewhere else, does that big, thick application form for being Medicaid eligible follow them, and they have to fill that out every time that we switch?
I can help you with that. Medicaid determines eligibility. The MCOs do the services. And so if they've qualified for Medicaid already, they're qualified. Because we're the ones. So as I like to tell people, if somebody's complaining that they aren't approved for Medicaid, they've been denied, that's on us. That's not on the MCO, because we're the ones that determine eligibility. So
DHS.
It's federal law that the Medicaid agency determines eligibility.
So there won't be that need for them to reapply just to change.
Okay, so I'm looking at our calendar here, and I want the MCOs to think about being ready to give an update here quickly, if you can. If that's not possible, maybe we'll work on it. But I do have one more question, or one more comment, I guess. I remember that when the MCOs came to Iowa, we had a lot of exceptions to what a lot of the other states were doing. And so they did have some problems with their computer systems not handling things right. And I hope we're trying to make sure that that's not a problem for the new one.
We are, and part of the onboarding process for Iowa Total Care, there are a lot of testing occurrences that will be happening. So there will be file transfers, there will be claims payments that were made, there will be candidate submissions to ensure that process is working well.
Yeah. Before the MCOs come up, I wanted you to back up just a little bit with the distribution of the Medicaid members. So we saw, like you said, Director Randall, kind of we don't want to repeat history, right, with the last time. We saw kind of a migration to AmeriHealth and got kind of lopsided there for a while. Okay, so now United Healthcare has the bulk of people, so you're redistributing people there. Number one, what has United Healthcare expressed to you in terms of they'll be losing members that they exist now, And have they talked to you about how that might affect their bottom line, or what they might do around that, or what was the agreement, I think, what, you know, initially when you redistributed them to United Healthcare, and now, you know, we have a third MCO coming on?
The only agreement, and to answer your question, the first part is that I think all three MCOs are aware of how we're moving forward with the onboarding of Iowa Total Care. We've had those discussions with how we're going to be distributing membership. I believe they are fine with how we're doing that. I think they want what's best for this program and for the members, so they understand that. With respect to the agreement, public agreement, the only agreement I'm aware of is that the third MCO would not come on board until a certain date.
Okay, all right.
And I could just also respond to that. You know, we've pushed pretty hard to the MCOs to say, if you're concerned about losing a lot of members because there's always choice, do a really good job. Make your members happy, you know? And that's kind of been the uniform message that I've been given to them. If you don't want to lose members, the best way to do that, you know, is to be the best show in town.
And I've echoed that as well in my conversations with them, not just from a member perspective, but providers. You know, go out there and build those relationships and really show them that you are wanting to be in this market, you want to move forward successfully, and I think all three are doing that. And we will see where we wind up on July 1st.
So, all right. So then we know that the MCOs have to have a certain percentage to be able to stay in the business here without losing money, right? So has Centene or Iowa Total Care expressed to you what percentage they need to do that? And then and how do you assist in helping them reach that? Is there some way that you communicate, you know, to membership, or, you know, how is it that you will, you know, you're on both sides of the fence, right? So you have
Yes,
allegiance to the member, and then you want to make sure that,
right,
that you are prescriptive to what CMS wants you to do around choice, so you have to make sure that there's that third or even fourth MCO.
Well, I think that, you know, I've had discussions with all three MCOs that we went through this process, and I think all three are in agreement. Iowa Total Care has expressed no large concerns to me relative to how we're moving forward with this. As Director Foxhoven said, it's your opportunity to go out and show that you are the best and that you can do things right. So that's why we set minimums, that's why we set maximums. We will monitor that. We adjust that with the algorithm. So depending on where, and one of the things I want to make sure people understand too, this is not, let's say for example, it's 55% is the max, and we make an assignment July 1st, and that takes one of the MCOs to 56% or 55.3%. Let's say there's a family of 5. I'm not going to separate the family. They're all going to be assigned to the same. So there's that familiar relationship. So we're going to monitor on a quarterly basis. So it might be 55, 56, but then we'll start adjusting the algorithm to get down to where we need to be.
Okay, all right. And then lastly, so in the initial bid for the work, you know, it came out WellCare, United Healthcare, Amerigroup, AmeriHealth. Where was Centene or Iowa Total Care on that list of scores? And then they must have been below that. And are you concerned about perhaps a low score in that initial bid? And have you talked to them about that?
I'm not aware of where Centene was. I was not here during that initial RFP and award for those MCOs back in April of 2016. To answer your second question, I'm not concerned. I think that we are working with them, and they have been very, very cooperative, supportive, very excited to be here in this market. I think it's a very good thing to have an additional MCO in this market, and so we will work with them, and they're working with us as we move forward, and I anticipate no significant concerns on July 1st when we start assigning members.
All right, thank you.
Okay, I see no further questions. So I believe we'll take the break now. Senator Bart and I are probably going to go to caucus, and so I'm going to turn the meeting over to Representative Heaton. Should we come back at 10:15? Let's try 10:15. We'll be back again.
Yeah.
Well, this told me that they would get $1,000 for something. Okay. Oh, okay, all right, thank you.
But I think it's, I don't know, like, I know it's not, you know, when the person's
Yeah.
it was benefit to them.
Yeah, and that's what she said it was like $1,000, and then it could go, I think it was connected to Walgreens, she said. And they could go in and buy or get free
Right, if you're
personal care.
yeah, your basic essential things that you could get.
You couldn't buy candy or it had to be medically related apparently.
Right.
Could they use it for co-pays? I don't think probably not, because that
I
would.
think it was so that, and this would allow them the money to do their own. So, you know, you can do your basic, your toothpaste, your deodorant,
Yeah.
your soaps or whatever.
And you have the money left
And they
over.
money left over to make it. So I think that's what, it's legitimate if you're looking to find out a little bit more.
Well,
I do know with United because I was also at a mental health criminal justice task force and I think like close to Story County spoke to us briefly about it. And I have her card in my office.
Well, I think what this person indicated is it's just sort of confusing people. And if you're, you know, like I say, if you're a low acuity person, somebody calls you on the phone and says, you know, hey, I want to have you switch and, you know, giving you this, whatever. You know, people, well, it's free, yeah, sign me up. Well, it may not be in the best interest of the patient to do that.
Right.
And that's my other concern.
No,
But it may be good, but maybe good too.
Yeah.
That's-
No, I think it's going to find out more. I don't have the packet of information. I know the folks that have realized it.
Yeah, well, that's the only thing I just want to get some clarification on that. Well, it seems kind of these people.
But I mean,
So your son's, he's a dual eligible?
no, he's not.
Oh, is that? Oh, okay.
No, he doesn't meet the age requirement for it.
If you can start preparing for that. Thank you.
Well, she didn't mention that.
That you invited me.
Yeah, my brother flies in Alabama. So, actually,
No, I'm not seeing.
that's Coach Saban. Well, no, he's saying.
Well, they're supposed to, the MCs are supposed to. So, we don't use it that often.
He started the program.
Some people.
Oh, fabulous. Well, when Penwell decided to go to Alabama, of course, she bought a home in Alabama.
Well, a lot of those
Yeah,
patients
she
are
moved to
right there,
Alabama.
so picking
She's
up their
originally from
medications.
And her both boys and daughters-in-law and grandchild. So, yeah, the minute the granddaughter says,
Yeah, no.
oh, that did it. Yeah, that did it. Yeah, so we're showing all our grad.
Oh, well.
She was very and it was, I came up to have my last brother taken, and I was down at the coffee shop in the village, and here's this lady out on the sidewalk walking her dog, and it was like 25 minutes. And so of course I said, you two are really cool, because I know we're going in. So I went into the coffee shop and got a coffee, and here she comes. I said, where's your brother? She said, oh, he was freezing, I had to take him upstairs. She was, can I join you? And I said, sure. And so she introduced herself, and I introduced myself. And I said, Joyce, I was here during the legislative session, I'm a state representative. And I said, oh, I'm so sorry, should I recognize you? Because I'm the new HR director. She said, I just heard about you in the pocket. So that was like a week before I started. Yeah, so we were, and then we found out the Alabama connection. So occasionally I would say, but before she left, my brother sent a t-shirt that said Alabama.
Yeah, we had that here. We bought
Well, and it wasn't, I didn't pay anything for it, so it was regifting. Yeah, she's like, I said, you never play nice with the neighbors, because it should be easy. And sure enough, there are several of her neighbors are Are you guys back?
Basically, it's a good change. It doesn't tell you which one has been turned down. That's a huge difference. So, it was the real as in the proof. It just really doesn't just tell you the data. The true doesn't tell you the community doesn't increase in or did they just occur decreases in and it just has a column that's marked. Yeah, it's usually page 5. It's table 5. And it includes children here, but it doesn't tell you to be equivalent. We just approve a change. Okay. I'll see if I can get better. Oh, no, I just wanted to tell you. Right. I just wanted to tell you that we have the 2 minute table, and since you were digging for more information, and I know that was a big issue, when we were talking about pre-ads for medical assisted treatment, and then for health savings, and the federal government is providing that through it. And the Department of Health has returned the text from that we were sitting with you, that's a medical. It's a medical. I'm not sure if I did, but Medicaid should not be doing that. But if it's a Medicaid rule, it should have to be some Medicaid, and then we do it. And I looked at it, I don't know that he really said, he just said it was for better and you've seen previous. I don't think we should, people should be as optimistic as we were. Everybody's like, oh, this is good, this is good, this is good, this is good. But no, then the records we have to ask for most of the the bring out their charges when I was flying, and then so we have considered the process, we have considered met that many times, it's how you take it from the side of the shed, and then we're going to talk about the needs of the continuous side
Yeah, that's kind of how I do it. Just kind of take an hour presentation, and that's a show.
That show up on time.
That's your charge.
No, this is the actual charge of the health benefit, and I dealt with it.
Someone from County will drive all the way to Lincoln County and take more of that miles. It's crazy. And so, except this time, this got pulled up. And she's, of course, made an 88-year-old right statement about the driver. And then she said, and and he dropped him just a power patient at first. Right. And then while that was,
Remember you were talking about
she kind of just
she walked and talked to me.
Okay.
Corridor talk.
The patient emanated.
It is, I mean, it's a medical.
Doing some other stuff.
It's not the one.
And she said,
So it's a medical. About what the
sure.
issue is. Yeah, it does have something. So
Right, and then after she after she
she just said that, you know,
I think that he was,
thanks for, I'm glad she was here to talk about it.
he was one of the you don't know, it's not oh, okay, they might have American.
They spoke last time. United. United.
Okay, can we all have a seat and we can move forward and finish up the day here? The last portion, before public comment, will be an MPO update. And United was not able to be here last meeting, and so they are here today. And so I'd like to invite Mr. Holtgren up to the table and fill us in on United Healthcare. Thank you.
Good morning, and my honor off here. Okay. And first off, thank you for the flexibility in allowing me to present today. I had a pre-planned family event the last time, and I would love to have been here with the other MCOs, but also needed to honor my commitments to my family, so I appreciate the flexibility with that. So I'd like to provide an overview, and given that I haven't had the chance to meet many of you, I wanted to provide a little bit of background on myself. And then we'll talk a little bit about what's been going on within United Healthcare for the last year. So my name is Bror Holtgren. I'm currently the interim CEO for United Healthcare of Iowa, our community plan. I've been in this role since July of this year, so about 5 months as the interim CEO. And I've been with United Healthcare for about 18 years, but before joining United Healthcare, I spent 10 years actually what I would call on the front lines of healthcare. I started my career in residential behavioral health, worked as a case manager for the population with serious mental illness, and also provided social casework services for children and families in the foster care system, so working with families with dealing with abuse and neglect. That experience, to me, has been really powerful in understanding how we as a healthcare system can work together to help people, our most vulnerable people in our society, navigate the healthcare system more effectively. Within United, my 18 years in United, I've held many different roles. The majority of those roles have been building and implementing programs for the most vulnerable populations, whether those are frail elders, individuals with physical disabilities, individuals with serious mental illness, and other individuals with complex care needs. That also has helped me see how we as a managed care system need to organize ourselves to understand what the individuals we're serving need and how we organize services around those individuals. I've seen managed care work. I've seen managed care work very well in helping people get services they need, and then also having an advocate to navigate what really is a complex healthcare system. Probably one of the most important things that I've seen is that oftentimes in a non-managed environment or non-systemic environment, we address services in silos, whether those are functional needs through our long-term supports and services, medical needs through your traditional acute care providers, or behavioral health needs through oftentimes a behavioral health organization. We know that none of us operate in silos. We have needs that interact with each other. So the ability for managed care to look at the whole person, to bring together medical, social, and functional, and create a comprehensive care plan for those individuals is where the power of managed care really begins to come through. As many of you know, in fact, as you all just talked about in the last session here, Iowa HealthLink went through a significant change in the last year with the exit of the AmeriHealth program last November. United Healthcare was ready to step in and help with that. I'm very proud to say United Healthcare was here to support those individuals. That transition, though, was very challenging. We went from serving approximately 200,000 members of Iowa HealthLink to 430,000 members of Iowa HealthLink, all within the period of about 60 days. That required us to hire hundreds of new employees, new team members. Today we have 650 plus team members serving Iowa HealthLink members based here in Iowa. The majority of those are case managers, people that are actually out in the communities across all 99 counties, working with our members, with your Iowa HealthLink population to make sure they get the services they need. During this time, our focus was on understanding what the needs were of the population coming to us from AmeriHealth, and also making sure they got those services. I'm not going to say it wasn't without its challenges. There were some rocky times for sure, but bringing that population on board, which also included the majority of those individuals receiving long-term supports and services, was, again, a very complex transition. Our team spent that time not only getting to know our new members, but also building a provider network that was significantly expanded. Again, bringing that population on required us to expand our network, not only in terms of size, but also scope, as well as to understand how to make sure we could get providers paid and address any issues that were coming up. We had issues. I think I've heard from many of you through the escalated issues process. When we hear about issues, my expectation is we address those directly with our providers, with our members, and our stakeholders to make sure we understand what the underlying causes might be so that we can address those and make sure people are getting not only the services they need, but providers are getting paid accurately and timely. I also want to take a minute to talk a little bit about value-based care. You heard at the last session from several participants, including Alyssa Weber, our planned CFO, about the value of value-based purchasing. I want to talk a little bit about the value of a managed care-based approach, such as you have here with Iowa HealthLink. The adoption of value-based purchasing is complex. It requires a provider to be able to understand how to take in data, understand high-risk individuals, interact differently with those individuals, and in many cases bear risk. We've seen the best way to approach value-based purchasing is through an MCO-based approach. What that allows is for the state to have a single accountable entity, or in the case of Iowa, three accountable entities, to be able to begin to promote and scale value-based purchasing across all individuals, regardless of where they receive services or whether they're seeing a large or small provider. It also allows for a consistency of quality, performance metrics, and also ensures that there is financial stability for the system overall. So as you think about the evolution of value-based purchasing, having a system that promotes value-based purchasing that can be flexible and working with providers, meeting them where they are, whether they're ready to bear risk, whether they're ready to take in data reports to be able to identify and screen for high-risk individuals, and to make sure that you've got a system that really focuses on quality, outcomes, as well as financial stability. What I would share is that United Healthcare currently has about 19,000 contracted providers in Iowa, and we've used this value-based approach to enroll 48% of our population in value-based programs. If you compare that to the contractual standard of 40%, we're very proud of where we've gotten to. We have a long way to go, I think, as a system to truly see the value begin to evolve through these value-based purchasing agreements, but we've created quite a large infrastructure and net that allows us to use our data and reporting capabilities. We have staff that are deployed to physician offices to help with practice transformation, to make sure that the practices understand the data they're getting and how to actually use that to engage differently with high-risk members. Finally, I'd like to share with you a couple of examples of how managed care has really created some benefit for individuals. If we think about what we do every day, it really should come down to how are we making sure our most vulnerable populations are getting the services they need, and are they seeing a better outcome than they would have seen in the past. I want to share with you 3 examples of what I see the value of managed care coming to fruition in the market. First, I'm going to read these so I don't miss any pieces here, but our United Healthcare team works closely with our members who are expecting, particularly those who have high-risk pregnancies, by providing educational supports and resources to expectant parents. We really focus on encouraging healthier deliveries, healthier babies, and healthier moms. One such case is one of our members named Dana. Dana is from central Iowa. She had a previous miscarriage, and as a result was considered high risk. We work with Dana and a variety of partners, so one of the things that's really important about managed care is we don't do everything ourselves. Part of the value we bring is organizing the system of care, existing community-based resources. And in the case of Dana, we did just that. We identified a resource, Count the Kicks, which is an Iowa-based nonprofit. I'm sure many of you are familiar with that program, and enrolled Dana in that program. They worked with Dana to understand that how to monitor the movement of her baby. And although her baby early in pregnancy was very active, late in pregnancy, Dana noticed a decline in activity, went to see her doctor, and was immediately hospitalized, where her daughter Nala was delivered safely and healthy. Her doctors and Dana both credit Count the Kicks with the healthy delivery of her baby. What we have done with Count the Kicks is to work with them both in terms of information referral, but also supporting them financially to make sure that they are available for these high-risk moms in our own community. Another example of one of our pregnant members, a 29-year-old member who's pregnant. She was also homeless and had battled many issues with mental illness and substance use throughout her adult life. Our care manager enrolled her in our Healthy First Steps program, which is designed to provide education, resource, and referral, again, for our high-risk members. She also worked with our member to make sure that she had transportation to her doctor's visits, and also enrolled her in homeless housing support programs so that we could get her on the list for consistent, stable housing. And then finally also worked to get her into outpatient rehab to address her substance use so that she could have a healthy pregnancy and healthy delivery. Finally, I'd like to share with you a story of a teenage member we served in Sioux City. Her name is Madison. Madison is legally blind. Madison also suffered from brain trauma. Our case managers have worked with Madison and her family to ensure that Madison's care plan addresses not only her medical and social needs, but also her support needs. But what's really interesting, and really where the benefit comes, is starting to talk to Madison about what does she want to do, what would make her feel more actualized and feeling like she has a more meaningful care plan. We identified for Madison the opportunity to enroll in a program called Camp High Hope in northwest Iowa. Madison was named a Smile Ambassador, which was quite an experience for her. She beams ear to ear when she talks about it. And through that, she was able to not only get the basic services she needed through her waiver, but also have a much more meaningful interaction that helped her achieve some of her own goals. So when we think about how we try to interact with our members, there's the basics, which is how do we make sure that we're operating according to contract, but the broader picture is how do we start to organize the system of care around individuals to meet their needs, That starts with understanding their needs, their wants, their desires, and bringing them into the center of that care plan. That's how we are approaching all of our members. Again, we have opportunities to improve. We're open and hearing those directly. We've been out talking to providers, talking to members, and are committed to continuing to improve and evolve and supporting Iowa in the evolution of Iowa Health Link. So, thank you.
Thank you for the presentation. We passed the complex needs mental health bill last year. Can you talk a little bit about your role as United Healthcare moving forward and what your role and expectations will be with that?
So I think, Senator Reagan, I think that in that case, we would want to work with the IME to understand how we can support. Again, our role is really to help the IME administer programs, but also we can bring experiences from other states where we've had successful evolution of programs, whether those behavioral health, substance use, or physical health. So we're looking forward to working on what we would call thought leadership and looking at what are some solutions that we've seen be effective in implementing the expansion and evolution of the behavioral health supports.
So have you worked with the counties at all since it will be a regional?
So we do work with the counties today as well to look for opportunities to wrap around the existing Medicaid benefits. So our focus there is we have a core set of benefits we operate within, whether those are waiver or base Medicaid, and then working with the counties to fill those gaps. I think there's going to be some interesting opportunities to collaborate and partner around filling those gaps. I especially think about the challenges we have with some of the levels of housing, either housing support or programmatic support for people that we want to maintain in the communities. I'm an advocate, a fierce advocate actually, for keeping people in the least restrictive setting possible, and I think we've got some gaps in the system, and if we can work together and find ways to solve for those, that'd be a lot of fun, actually.
Senator Mathers?
Yes. Thanks for coming today, and welcome to the committee meeting here. My first question is about training your case managers. Occasionally we get providers who will say, we feel like we're training the case managers, and teaching them how to be better case managers and working with them. Can you just briefly give us an idea, as an oversight committee, how do you train your case managers? And do you put performance measurements in front of them? How does this look when you train them?
Yeah, Senator Mathis, thank you for the question. I think so. The first to address the question head on, we do have a comprehensive training program for our care managers that differs based upon their role, whether they're an assessor or an ongoing care manager. What I can tell you is, as we've worked through this transition of bringing on hundreds of new care managers, we've been getting better. We've been getting better, trying to get to more consistency to make sure people that we have in our employment understand the programs and understand expectations around how to engage with our membership and our providers. One of the challenges when we look at the care management structure is having people that are serving multiple waivers. So we are evaluating how to really identify who are the specialists in certain populations so that we can make sure that they are effective in that. We do use I would call it multi-layer. So our Executive Health Services Director does skip-level interviews to make sure that we're seeing from a senior level, engaging with our direct line and our management staff. Our managers do set performance metrics for our care managers around timeliness, completion of services, as well as accuracy. We use a peer review process or iterative reliability to make sure that we've got consistency in the application of the tools. And most importantly, we want to get feedback. So when things aren't working, we want to hear about it. When things are working, we want to hear about it. I just got on the break, I had a sidebar conversation and heard about one of our care managers who was really doing a great job. So we love that too, to hear when people are doing a great job. This was, as you would imagine, a challenging job. Having done care management with complex care populations, I can attest to that as well. It is even more challenging in a period of heightened change that we went through over this last year. And so we're committed to making sure we have consistency and effectiveness in our care management staff, and most importantly, that we have a culture of embracing our population. So really kind of understanding that our care managers are here to help people and be advocates.
Is United Healthcare going to continue to pursue the health homes business?
So there are the two variants, correct? So the integrated health home, or IHH, and chronic care health home. We will work with the IME around their strategies. I think the challenge. I heard your question about the intent to exit that. That was last year. I think we were concerned about potential duplication of our care management service with chronic health home. I think about chronic health home and integrated health home all part of the continuum of value-based care that we have a commitment to. I think the question is, how do we make sure those programs are addressing the needs of the population that are enrolled, are not duplicating services, and are truly driving the results that we want to see. So I'm committed to having to supporting programs that address again the outcomes and truly serving the populations. I don't know if that answers your question. That was a little rambling. I apologize.
It does. It was fine. It's a deep question. Thirdly, we've got a lot of feedback here.
Sorry.
Yeah. You might want to move that metal clip that you have there. I don't know if that has anything to do with it. The redistribution of population will be coming once Iowa Total Care comes on. Tell us how you're preparing for that, and will we see layoffs? Will people from United Healthcare be laid off?
So first, to address the overall redistribution, we've been working very closely with the IME and I apologize, I will try to make sure I'm looking at everybody here, but very closely with the IME to understand the intent. We fully support the need for competition. We embrace that. I think competition makes us all better. And we also understand the need for the state of Iowa to have choice in the MCO, the MCOs available to Iowa Health participants. We certainly have concern with the loss of a relationship that we've worked hard to build with our membership, and we heard Director Foxhoven say it very clearly. It's been a very heavy focus of mine is I want to make sure I'm serving people in a way that makes them want to stay, whether that is our membership, whether that's providers. I want to be the best service provider for those individuals to really want people to stay. The reality is there will be some redistribution. So my expectation would be that we want to do that in a way that's planful, so that people that are leaving, we have the ability to share information, share care plans to make sure there's no interruption. I think the timelines that the department has built in are going to allow for that, where with the AmeriHealth exit, it really did not allow. That was a very short time frame. So having the ability to plan ahead and make sure we have good handoffs for anybody who's changing is really important. In terms of layoffs, I certainly can't speak to that. My goal is I'm committed to my staff, again, 675 Iowa-based employees. The reality is, and I think someone mentioned this in the last session, it's likely that Iowa Total Care will be hiring some of those staff. And that's normal, that's expected. We certainly want to keep our staff as well, but we will need to continue to make sure that our program matches the population we serve. I think that's about as much as I can answer of that question at this point. We're going to work hard to keep the members we serve happy and well served, and our providers, again, satisfied with the services they're getting from us and the payments they're getting from us, and that also goes for our care management staff. So,
thank you.
You bet.
I'd like to have you explain to the panel a little bit more about value-based purchasing, how it's structured, and then also how the providers take risk. In other words, I think we need to really fully understand, as you move toward value-based purchasing, what does it look like and how will it affect our providers?
You bet. And I would first start by saying any movement towards value-based purchasing is in partnership with providers. So in no case would a provider be forced to enter into an arrangement that they were not happy with. So just to start there, with it, it's really an opportunity to engage at a different level with providers and to help them to address the populations they're serving in a different way, and then also provide them with reimbursement for the outcomes produced. Pay for value, or it's really, there's a continuum. Think about a continuum of either risk and benefit. The lowest level really is establishing specific metrics, whether those are meeting specific quality metrics or performance metrics that we believe will produce the positive health outcomes. and paying providers for those. So we can, in fact, in cases, have a contract with a provider that pays them for helping us achieve the performance guarantees that we have in place with the IME, whether that is through improving well-child immunizations or improving the follow-up post-psychiatric hospitalization. Those are all metrics that we need to work together with providers to achieve. So we can meet providers where they are and establish contracts that just simply pay for the performance of those metrics. Can also begin to start to pay for outcomes. And again, it would be a supplemental payment to services that they provide. When we get up to the higher levels, you start getting into the accountable care organization structures, which exist here in Iowa. It's probably where the bulk of our membership is today. In those cases, we have specific requirements for the providers to meet to essentially organize and engage with members in a way that we believe will create the right outcomes. But then we're able to share some of the savings with providers that result from improved health outcomes and reduced costs for that population. Risk bearing is the next step up. There are very few providers today that are truly bearing upside and downside risk, and in Iowa, we're not there yet. But there's an opportunity for providers to move all the way up and down that continuum based on where they are. Managing risk is challenging. It's difficult. We would never want put a provider in a position where it would destabilize them. They're too important to our ability as Iowa to deliver on the healthcare system. So there's a continuum. We try to meet providers where they are and make sure that we can not only address and share with them some of the benefits that come from positive health outcomes, but also make sure that we're not putting them in a position that will destabilize their practice.
So I just kind of want to get it into see it, so I see it for real.
Yep.
Let's say I'm an orthopedic surgeon, and I have a client, and we're going to replace a knee. How are you going to address value-based purchasing with that orthopedic surgeon?
You bet. And so that as a hypothetical on a surgical procedure, or it might be paid through an episode of care. And these are standard approaches that we've seen in Medicare and other areas that might say, here's the cost of providing this specific type of service, and that if you can do that more effectively with less cost and then also shorten the length of stay, that there might be some sharing in that benefit. Again, we don't today in the Medicaid business. We're not entering into episodes of care on surgical, but that would be one way to do it. To say to you, the average cost of providing that knee replacement, I think that's what you were speaking to, is X, and we're going to pay you some portion of that. And if you can do that more cheaply, great, but then also tying to that quality outcomes. Did the person go home, and did they stay home? Did they have a successful recovery? Anything we do in value-based care needs to address cost, quality, and outcomes. And so just to be really clear about that, you can't just pay for decreased costs. You've got to improve quality, and you've got to make sure that we're keeping people healthy.
So, in other words, in paying for that operation, that surgery, the surgeon will get upfront money to do the surgery, but then he as whether or not it's successful and the results of it, then he gets additional payments if he's successful, or how? I'm trying to.
Yeah,
I'm trying to get a handle on how the cash moves through the system.
So it's a really challenging example because we don't do what you're here in Iowa with Medicaid. We don't do that. Maybe I could give you a different example.
Okay,
Would that be okay? Okay. And I apologize. I don't mean to. So if we had a primary care physician that had a panel of individuals that they serve. So let's say they had 1,000. Let's say it's a clinic with 1,000 enrolled individuals. We could look at setting a target for that practice to say your average medical expense is X, and over the course of a year, if it comes in less than that, we'll share some portion of those savings with you. So they get paid as they typically would, but then they have the benefit of realizing the gain of some of those savings, but only if they achieve specific quality and access measures that were kind of the gate to be able to tap into that. So what we would not ever want to do is incent somebody to reduce services. What we want to do is promote efficient use of services and effective improvement of quality.
Is there a lot of paperwork that goes along with that? documentation?
There can be, for sure. But
More than conventional approach?
typically what we would try to do is to try to make sure we're using traditionally reported measures for quality. So the HEDIS, which is a standard measure for standard system for reporting quality metrics, we typically would use HEDIS measures so that there's not an incremental burden on the provider. They would be reporting as they do for any other care.
So in other words, when I look at the clinic, you're giving a capitated amount of money to take care of a certain population within the clinic?
No, I apologize. In this case, the most simple case, we're paying them as if they were contracted fee for service, but sharing some savings with them. So this is, if we just want to boil it down to really simple, we have a continuum. There's a continuum or a range of services, and we really try to meet that provider where they are. And if they have an interest in value-based purchasing, we would want to make sure that it works for them, works within their existing practice structure, but that they would be doing something additionally to make sure we're driving to increase quality and outcomes.
So this is going to be a voluntary thing?
For sure, yep.
Do you see the day when it won't be voluntary and that's the way you do business?
I don't think that would be, I can't see the future for sure, but for me, this is about partnership. That's the key issue. It's about partnership, and involuntary partnerships don't tend to work that well. So I would say that this would be about how do we work together to improve health and outcomes for individuals.
I know the Medicare when they take a look at value-based purchasing, they look at the ACOs and we have this SIM grant where we're putting together these ACOs, and I understand that there'll be a day when Medicare will come forward and say, you cover this population per member per month, this is your money. And that ACO will provide the services to that established population within that organization.
So I certainly can't speak to what the national Medicare strategies are. I certainly see that Medicare is promoting the use of ACOs as well, and that's based upon, I think, some positive demonstrations that have occurred in the Medicare space.
Representative Ford.
So, on value-based purchasing, I mean, we're talking, say, if a clinic has, say, 100 patients that have diabetes, and you're saying they're going to be paid on a fee-for-service basis under this value-based plan?
So to be very clear, that was a hypothetical. There are ranges. There is a way, yes, that, and I'm really trying to go back to how do we break this down? I'm not really intentionally not describing an existing value-based contract because there are so many different variations. Okay. So I apologize for.
But let's just do a hypothetical here. So you say you've got 100 diabetes patients in your practice, and you're in a fee-for-service program under value-based care. Then are you? I'd assume if it's fee-for-service, you're going to accept maybe a lower amount, maybe, knowing that on the back end you could get paid more if you have better outcomes for these 100 patients. So if they reach their A1C goal, a lot of them have hypertension and things like that go along with it. Would they, at the end of the time period, get reimbursed, the physicians now, an additional bonus payment because they've done a better job in managing these patients, this group of patients?
So, again, there are many variants of how we think about pay for quality. What you're describing really is pay for quality, where we would establish a metric to say if we show compliance with hemoglobin A1C, can there be an additional payment? So yes, there could be, and it would really be based upon the agreement that we would reach with that provider. And not wanting to go into any specific contractual language here, but we have the ability to, again, meet providers where they are, but come back to the key constructs. Are we improving health and quality? Are we doing the things that we think will result in better outcomes and better from both a cost and quality perspective? And how do we make sure the provider is getting paid for those? So there's a continuum, whether it's paying for closing a gap on a quality metric, all the way up through some sort of sharing of total cost of care. And again, it's a very, very wide range of opportunities out there. But the benefit of delivering value-based purchasing through a managed care structure is we can create those very flexible and very focused and targeted provider-centric approaches that address the needs of specific populations.
Okay.
Well, I'd like to thank United Health for coming forward and telling us about your performance this last year. And we'll look forward to seeing you again, okay?
Thank you very much. Appreciate it.
Okay, the next portion of our program, we're going to deal with the presentations from Delta Dental and MCNA. So I'd like to ask Delta Dental to come forward and bring us an update on your dental program that we have for our Medicaid population. Please limit your comments and discussion, I think, for about 15 minutes is about what we have. We're up against this thing with caucuses and all that kind of thing. So if we could hear from you, we'd really appreciate it.
All right, thank you for allowing us to present today. I'm Gretchen Hageman, and I serve as the project director for the Dental Wellness Plan at Delta Dental. And this is Dr. Jeffrey Chaffin. He is our Vice President of Professional Relations and our Dental Director. It's very important for Delta Dental to have a dental director for the clinical aspects of Medicaid and commercial. He's going to help me with questions if you guys have questions about providers. First of all, I want to thank you very much for your continued support and leadership for allowing Delta Dental to be part of a comprehensive package for Medicaid adults. And I want to thank Representative Heaton very much for your dedication and leadership for pushing dental always the last many years. So thank you. You'll be missed by very many at the Capitol. So we're proud to be a leader in dental. We helped the Department of Human Services and Iowa Medicaid providers and family advocates start the dental wellness plan back in 2013, if you remember. Medicaid expansion was coming in and you added dental to legislation, and so that began a lot of conversation in Iowa of how you look at innovation and what that looks like for dental and how we push the member accountability piece of Medicaid too. So we're a nonprofit organization. We are the largest insurance company in Iowa, and we provide Medicaid benefits for the Hawkeye members and the adults for dental wellness plan, which includes Medicaid expansion and Medicaid. We give back through our foundation for in supporting oral health initiatives in all 99 counties. As you know, oral health is very important for a person's overall health, and research shows that if you invest in dental health, you're going to save on the medical side. When we looked at the emergency room data from Iowa Hospital Association for the time period of 2014 to 2017, there was a decrease in the number of adults that presented at the emergency room for dental pain. That decrease was about 14.6%. And you could, during that time frame is when you had implemented the dental wellness plan for, you had fee-for-service Medicaid and you also had the dental wellness plan. So you can see there as they're going to find a dentist, they're finding a dental home, and that saves money for Medicaid in the long run. So now I'm going to talk a little bit about the dental wellness plan, state fiscal year 19, which we're in the current, start July 1st. You have a new structure for the dental wellness plan. It is a two-benefit structure. You have full benefits and basic benefits. Full benefits gets a member very comprehensive services with an annual benefit max of $1,000. There's also some excluded services. So if you go to the dentist for preventative services, a denture, an emergency type situation, and then any sedation with oral surgery. Those are all excluded from your annual benefit max of $1,000. So then you also have to complete your healthy behaviors. So members have that member accountability piece. Healthy behaviors is a self-assessment, oral health self-assessment, and a preventative service. If you do that as a member, you stay on full benefits. You have to complete that annually with your enrollment period. If you don't, you have the ability to pay that $3 premium, very much like health, or declare hardship. If for 90 consecutive days you don't complete your healthy behaviors, pay your $3 premium, or declare hardship, you then move to basic benefits. So basic benefits are essentially preventative services and emergency type services. And the member stays at that basic benefit for the entire enrollment period. They can do their healthy behaviors, but that will get them back to full benefits at their next enrollment period. So if We have members now that have moved to basic benefits as of December 1st. They have until July 1st to complete those healthy behaviors. If they do, they'll be pushed back to full benefits. Okay, so right now, Delta Dental serves about 110,000 members. There's about 320,000 members that are part of Medicaid and Medicaid expansion. 27% of those members have had a service through Delta Dental. Our target is 30, and so we've had roughly 4.5 months of our contract, so we're at 27%. If you boil those 27% down a little bit further, a quarter of those are brand new, so they've never had a service. That may be because they're newly eligible for Medicaid, or that may be because we're working on our outreach efforts and getting them in to find a dental home. And 62% of those services that they've had are preventative. So once we get them a dental home, they are coming in for prevention and they're coming back for their recall appointments. About 95% of our members are still at that full benefit. So we have very few members, about 11,000 that have moved to basic benefit as of December 1st. And then 275 members have hit their $1,000 annual benefit max. That annual benefit max started September 1st. It goes from September 1st to June 30th. So 275 have hit it already. So our outreach structure works with members that our primary focus is healthy behaviors. We want them to complete their healthy behaviors. So we do recall, we do text messages, mailings, and phone calls to those members monthly until they complete them. So once they complete both categories, they fall off our list and they've completed it for the year. We also do text messages and phone calls to members that have their 6-month annual or their 6-month preventative service. And then we do postcards and text messages to people that have never come into the dentist. So encouraging them to find a dental home through us and call us. We also have a care coordination structure. So if we have high-risk members that need care coordination, we work with them. A lot of it are disabled, some pregnant women, and some of our members that have turned off of Hawkeye and come on to Dental Wellness Plan. It's a little bit different benefit plan, so we do a lot of care coordination with them. And we're beginning discussions with the medical managed care organizations to look at integrating care coordination so we can better serve the member and address their dental health issues. So right now we have about 1,000 providers, part of our Dental Wellness Plan network. So 1,000 providers can provide services for a Dental Wellness Plan member. About 50% of them are accepting new members. About 50% of that, about 500 of them are accepting new members. So if you've heard from some providers in your area that they're just not accepting new members, so about 50% are not accepting, and when you drill that down, so that 50% that are not accepting, 38% of the members serviced are getting care through them. So that dentist is still seeing Medicaid members, it's just their existing members that they were servicing. So they've reached a practice full, their practice has become full, and they are not accepting new, but they're providing services to their existing Medicaid members. About 15% of our members are served through our federally qualified health centers. And that's an increase this year. Last year it was about 12%. So this fiscal year we've obviously seen an increase of members not accepting new patients. It went from 35% to 50% already in this fiscal year. And providers will tell you it's administrative burden, it's the complexity of the plan, so they have to check, if the member's on full or reduced, they have to check their annual benefit max, they have to check eligibility if they're, who they're with. So it can become complicated for a provider in the provider office to make sure the Dental Wellness Plan member is actually can get services. And since they're small, most of them are cottage industry, they own their own practice, so it becomes a financial decision for them. But we hear, Dr. Schaff and I hear a lot of providers want to provide services for older Iowans and the disabled. And so they'll continue to take members based on that and provide them services. I wanted to end with a member story. So we have lots of successful member stories, but this one is a 50-year-old man, and he is wheelchair bound in eastern Iowa. He was getting services in the University of Iowa College of Dentistry, and so that required him to work with his medical managed care organization to get transportation lined up to get there. And it was, as you can imagine, a full day process for him to get one dental service. And so essentially he was only going there for emergency care. He was, after he became wheelchair bound, he stopped going regularly and just went to them for if he had a cavity or needed a crown. So he called our office and we worked with him. He now has a provider 10 minutes from his house in his eastern Iowa town, and has really established a dental home with that provider, has been to 2 preventative visits, and has completed all his healthy behaviors, and he continues to keep us informed of issues if he has them. So that, if you think about saving money for Medicaid and as a big picture of getting him care closer to home, saving money, it's one of our success stories. What questions do you have for us?
Any questions from the panel?
Thank you for all those statistics and the story. And so this is really the first time in quite a while that we've heard from dental, and that's good. It's a good thing that we've got all of this evidence so that we can ask you questions. The first 3 letters and contact that I received when Iowa was going from fee-for-service to managed care, the communications were from dentists. They were worried about reimbursement rate. One just said she had written a letter to 200 of her Medicaid patients and said she was going to leave the Medicaid business. She just wasn't going to take any more Medicaid plans. Another of my dentists in Marion just retired, and the dentist that bought his practice is not taking Medicaid because the retired dentist, who was really very adamant about, he really wanted to take Medicaid, but he said he had reached the tipping point where the reimbursement it was not going to pay his staff to be able to do that. So my question to you, both of you, is when you have dentists that you can see maybe are on the tipping point, and that community really needs a dentist to, be in that Medicaid program, how do you work with the dentist, or can you work with the dentist in trying to get them to stay in and serve that population that needs them the most?
Sure, we definitely try to work with those providers because it's important in some of those small communities that we have providers there. We can't change reimbursement for the individual provider, but we can try to decrease some of the administrative complexity. We go in and train, so if they learn the program, if they understand the benefit structure, then they tend to have less problems with the administration of the program, but we definitely try to reach out with them.
All right. And are you seeing, I know maybe one of the statistics indicated that there are fewer dentists who are, or did I not hear that right, that are taking Medicaid patients?
So going from Medicaid expansion, we just had Medicaid expansion in 2017, they brought all adults in. So we went from 850 to roughly like 1,100 dentists at that point.
Okay.
And so this past year, if you think of, we almost had a year and a half of that fiscal time period, we've lost about 100 providers. And this fiscal year is about 16.
So if I could follow on, we have about 1,000 providers in the Medicaid network, in our Medicaid network. In Iowa, we have about 1,680 Iowa dentists in our commercial network. So it's still a good percentage of overall dentists that are participating in the program.
And what are some of their chief complaints to you? Or, Director Randall was saying that there are these subgroups or subjects that they were identifying when they were talking to some of the providers, like provider credentialing, appeals, prior auth, and member benefits. What are some of the things that your providers have been talking to you about improvement in some of those areas?
Yeah, so Director Randall did touch on a few of them. So the complexity of the plan, they went from a very comprehensive benefit for just a Medicaid individual. Now they have to figure out if the individual is full or basic. So if you're basic, you're not getting, you can't really, you have to extract the tooth essentially, that's what happens. And so the complexity of the plan is definitely an issue for them. Dr. Chaffin talked about reimbursement. We also hear Dr. Randall talked about prior auths. So off the top of my head, I think we have about 260 dental codes that require a prior auth. Dentures is a good example. If you're prior authing a denture and you're, as a plan, you're approving 98% of them, do you really need a prior auth on that? And so that's one area where providers have talked to us a lot of. That extra step of prior auth can be a burden for them. And then, we also work with providers and members if the no-show rate is still pretty high. Providers will tell you that's one reason that they eliminate people from their practice. And so if they send us a message, we then provide care coordination and education to that member to say, you need to keep your appointments, you need to keep going in. So that's one area too.
Thank you.
Well, before we move on, I just wanted to let the audience know we're one of 13 states in the United States that offer dental care for Medicaid. One of 13.
So there's 47 states that offer dental care for Medicaid, adult Medicaid. One of 13 that offers a comprehensive plan. And nationally, if you think about that, we've definitely been highlighted a lot of, we offer a very comprehensive benefit to adults, and we also put in that member accountability piece. If it would, as part of the first dental wellness plan, now you have healthy behaviors. So the other 35 states just offer a basic emergency or limited adult benefit for dental.
Thank you for
Yeah.
correcting me.
No, you had the 13, yeah.
Thank you very much. And now, if there are no further questions, we'll look forward to MCNA Dental and Renee Canales to come to the table and talk about his company and his approach to our dental service. Thank you so much.
Okay, good morning everyone. My name is Renee Canales. I'm the Associate Vice President of Network Development for MCNA. Thank you to all members of the committee for giving us an opportunity to present here today. I want to just give you an overview of MCNA and how we started, who we are, how we conduct our business, and what our approach is. MCNA has been in existence and providing Medicaid and CHIP benefit services for over 25 years, and we basically focus on government programs in the states that we're in. We currently serve 4.5 million members, that's adults and children, throughout the country, and we have direct contracts with states in 9 states currently. We're in Texas, Louisiana, Florida, Iowa, Idaho, Nebraska, Arkansas, Utah, and beginning in 2019, in July of 2019, we will have the contract with the state of Washington as well. We were founded by a periodontist, Dr. Jeffrey Feingold is a Florida licensed periodontist and a diplomat of the American Board of Periodontology. It's a family-owned business. And we're headquartered in Fort Lauderdale, Florida, with regional offices in San Antonio, Texas, in New Orleans, Louisiana, Lincoln, Nebraska, and Little Rock, Arkansas. Our mission and approach to managed care is to deliver value to our clients and providers by providing access, quality, and service excellence that improves the overall oral health outcomes of our members. We understand that an emphasis on preventive dental care basically improves the overall health of our enrollees And that's something that leads to the overall cost savings in the states that we are conducting business. We take a proactive approach to utilization management and cost savings by evaluating the medical necessity of services before they are provided. And basically what MCNA does is we hire actual dentists in the different disciplines that are available to review claims that require medical necessities or any of the claims that are denied. We have dentists that review those claims, and it'll be a dentist of that like specialty that will review. And then we encourage our provider offices to reach out to our dentist for peer review or to discuss how we approach this method. MCNA also focuses on quality assurance. In 2014, MCNA became the first dental plan in the nation to receive full dental accreditation from URAC, and we currently received re-accreditation in 2017. We are also accredited by the NCQA for credentialing and re-credentialing, and we've been doing this since 2012. MCNA is also a member of the Dental Quality Alliance, which is a national organization established by the American Dental Association to advance performance measurement as a means to improve oral health, patient care, and then we do this through a consensus building process. So we work with the dentists from the organization, and we work together to talk about how things have happened throughout our other benefit plans throughout the different states that we're in. And we collaborate on evidence-based information to determine that we're on the right track of ensuring that we are focused on quality. We also have leading-edge technology to help providers work with us and how we conduct business. We provide a free web-based provider portal that allows providers to submit claims, submit prior authorizations. They can also review claims history through our provider portal, and so it helps them address the healthy behaviors that have already been met, and it works in collaboration because we need that information to pay claims accordingly, and they have the information to ensure that the services that they need to provide have already been done or have been done by other providers or something to that effect. And then we also have our documentations, like our provider manual is available through our provider portal, and other resources are also available. At the close of November, 99.6% of our Iowa providers have used our provider portal. We also participate and support the Iowa State Dental Association, and many of the events that I've participated in, we've had several providers that will come to our booth and talk about how they love working with our provider portal. It's very user-friendly. They can get their job done and submit claims without a cost associated with it. And so they talk about how it helps them conduct their business through the provider portal. We have a dedicated customer service that helps with our members. We have integrated call centers in both Texas and Florida, and that helps members minimize wait times for them and for our providers to identify anything that they might have issues with. We also help to educate our members on the benefit structure and where they are in terms of meeting their benefit requirements. Our member service department has a robust training program where we have a first call resolution and cultural competency. If you remember, Gretchen was talking about how the benefit structure is a bit complex, and so we're constantly providing education to our members to make sure that they're meeting their requirements in terms of completing their assessment forms, and then also to get their first preventive service out of the way so that they can have full benefits. And so we do this when members call our member customer service hotline. we can tell from our system whether they have met those requirements or not, and so we direct them to do so. If they haven't done so, we provide education, and that way they have an understanding of what their responsibility is. Many of our member service representatives are multicultural, and then we also offer translation services in nearly 300 languages. Some of our call center statistics, just to give you an idea of how robust our member hotline is. We average a speed of answer less than 2 seconds. Our abandonment rate is less than 3%, and our average hold time is 2 seconds. The same for our provider hotline. We also maintain those statistics, and the average speed of answer is less than 2 seconds. Our abandonment rate is less than 3%, and then our average hold time is less than 2 seconds. As I was saying, we are constantly providing outreach to our members. We use the education and outreach methods to increase appropriate utilization, including our member handbooks and oral health educational materials that are available online. We participate in community service events throughout the year. We probably go to 4 or 5 a month throughout the state. And so this is where we provide outreach. We pass out materials. We talk to members and their families to see where they are in terms of, are they getting their care? Are they having a hard time accessing care? And so we talk to them about those things and how we can help them attain whatever their need might be. We also focus on increasing the oral health literacy of our members and the community at large, and this is what I was talking about. We have materials that we can help them with, and then we have outbound calls where we're outreaching to members that haven't attained any of their benefit requirements and provide education at that level. Today, MCNA has processed over 210,000 claims for dental wellness program members, and with an average turnaround time of 11.65 days. The majority of those have seen a diagnostic or preventive services. And we also do mailings to help them get that information if they haven't done so. We do outbound outreach calls as well. Our member and provider satisfaction, MCNA conducts member and provider satisfaction surveys as part of our quality improvement process. Our overall member satisfaction rate for 2018 is 96.46%, and the overall provider satisfaction is 81.4% for 2018 end of year. One of the ways that we are looking to enhance participation in our program, right now MCNA has 502 unique providers that participate in the program. That's about 792 access points throughout the state. And so we are continuously outreaching to non-contracted providers to see if they're willing to participate with MCNA. It is somewhat of a challenge. Some of the challenges that Gretchen just talked about is missed appointments from the Medicaid population. The fees are too low. And then some of the other things are the administrative burdens that they feel they have. And I think you mentioned earlier that they don't have enough staff to have to do the extra little things that they have to do to submit claims, to get prior authorizations approved and things like that. One of the things that MCNA is considering doing, and we're pretty much there, we're finalizing our logistics, and then of course we have to submit what we want to do to IME for approval, and then once we do that, then one of the things that we want to do is we want to launch an elite provider program here in Iowa. And basically what that means is that we'll recognize those stellar providers that have complied with the requirements of submitting claims or prior authorizations and complying with the requirements of managed care. And so for those providers that are stellar, have been complying, we know that they're doing a really good job. Then what we would do with those providers is we consider them as preferred providers, and then we pull back on having to submit prior authorizations for certain requirements, and we will call that an off-pass, bypass, where they can bypass the clinical review process for qualifying services and providing stellar performances. So that's something that's in the works right now, and like I said, we will submit that to IME for approval, and then once we get that in place, we'll implement that with the goal of implementing first quarter in January. So we feel that we are an experienced and reliable partner. Our strong relationships with the provider community and our commitment to quality of care for our members has made MCNA a national leader in dental benefits administration. As I was mentioning earlier, we contract with 9 states currently, and we really contract in states where they carve out dental. In other words, dental is not part of medical, but it's carved out as a standalone program. And so those are the states that we basically target. I think there's like 13 states that do direct contract with MCOs, and we are in 9 of those now, currently. We're grateful for the opportunity to partner with the state of Iowa to serve the Medicaid program. We encourage you to visit our website at mcnaia.net for the most up-to-date information about the program. And we're continuously working with all of our partners, including IME and Delta Dental, to try to find ways to make the program more efficient and then, of course, more successful. Thank you very much for your time.
Any questions?
Thank you, Mr. Chair. Just curious, one of the biggest obstacles when I meet with dentists in the area, and we had a meeting here recently, and it all boils down to reimbursement. A lot of them don't participate, and I've been told that they're getting paid maybe 30 to 40% of their normal fee. Who sets the fees for services that when you pay dentists? Do you set them, or does the state set those? Or?
For the most part, in how we do it in most states as well, is the state hires an actuary, thank you, that determines what fees are fair for a program of this type, and so we usually go with that. We're also not prohibited from offering higher fees in areas where there's a big need as well.
And then let me ask you about your admin fees or administration fees. Do you know what percent admin fee you have in your program? Is that something you can share with us? Or is it...
I think it is something I can share with you. Unfortunately, I don't have that figure. I'm thinking, I don't know if you know, Director Randall, it might be 15%, but that's a guess.
Okay.
I can get that information and make sure that you get that.
And then, what about other states? I mean, are rates similar from state to state, you see, in reimbursement? Because
it's pretty low. I know that Texas has a really high, probably one of the highest reimbursement rates in the country. The state of Texas has a really strong lobby that's part of the Dental Association. And so the Dental Association has a robust lobby where they can work towards that goal.
And you guys, you're participating in your dentist in the Hawkeye dental program here in Sierra Leone?
Currently.
No.
Just Medicaid adults.
Okay, because I've been told that on the Hawkeye program, reimbursement rates for dentists are higher. And that's why some dentists will participate in that program. But when it comes to the core program, I guess you might say,
right,
most Medicaid, a lot of them don't. So
it's true. It's one of our challenges. It's one of our biggest challenges, and that's why I said we are constantly trying to find ways to see what we can work through to make it a little bit easier for them.
Okay, thank you.
Well, thank you for coming forward today. we're running out of time.
It's quick.
Go ahead.
Okay, on slide 8, you have, to date, MCNA has processed over 210,000 claims with an average turnaround time. By turnaround, what do you mean by turnaround?
That we pay those claims timely.
Okay, so they are paid claims then. Are denials included in that 11.65 that you would deny a claim and then it goes on to appeals of the total amount of claims?
Because, yeah, they're not paid, they're denied, so they would not be included.
Okay.
It's only the ones that are actually.
All right, so you've processed 210,000 claims in all, right?
Correct.
So 210,000 are not just those that have been paid. They're all the claims that have come
No,
to
those
you?
are the ones that have been paid.
Those are the ones that have been paid.
And then the ones that have been processed will include the denials.
So how many total claims then?
that
So how many
information.
total?
I'll get that
Can you?
information for
Okay,
you,
thank
absolutely.
you.
Any other questions? Thank you, Renee.
Thank you so much for your time.
Renee, appreciate it very much. We'll now move on to public comment. And before we get started, I want to also say that we're going to limit these public comments to 5 minutes apiece, and I'll be keeping track of the time. And if we have to pull up short from what you have to say, you can always give us a submit written comment so that we get the full story. So we're moving forward now with public comment, and our first person to come forward is Jim Fox of Options of Lynn County.
First, we want to thank Representative Heaton for all the years you've put in here. You've been a friend of the disability community, and you're going to be missed. Happy retirement. I'm just going to read real quick so I can get this in. I timed this, it was 4 minutes and 50 seconds. We believe that Iowa should remove administration of reimbursement for long-term services and supports from managed care and return it either to a fee-for-service system or develop its own managed care independent of traditional Medicaid. Now, the first person I recall hearing this from in a public forum was Director Foxhoven when he was on a panel with Senator Mathis at Iowa Ideas Conference a little over a year ago. We felt it was a great idea then. We continue to feel it's a good idea now because the nature of long-term services and community-based services just don't fit the traditional medical model. Now, this is how most states are doing it, and I would encourage Iowa to look into it because I believe it's the best model for us. We'd like the Oversight Committee to address the conflict of interest that are inherent in the tiered rate system. Individual tiered rate assignments are based on SIS scores. We contend the SIS is administered is not a valid, reliable instrument as sections of it have been removed and it does not address all relevant conditions. For example, we serve a number of individuals with Down syndrome who are exhibiting signs of dementia. In the SIS, dementia is classified as an other and is not taken into consideration when assigning a tier. As a result, a person that needs a high level of supervision is placed in a tier that won't support them. Furthermore, it is administered by employees of the managed care organizations. Now, the MCOs aspire to do great things, but they are in the end for-profit ventures. The insurance company has a financial interest in the outcome of the SIS assessment. If the individuals that administer the SIS are employees of the insurance company, how can we be sure that scoring is fair and unbiased? The same conflict also exists in the provision of case management services. Members can no longer feel sure that their case manager is advocating in their best interest or the best interest of their employer. And finally, tiered rates have adversely affected day programs across the state, with losses in our service area ranging from 12% to over 50%. When the rates went into effect, supported community living programs, 24 residentials, were given 18 months to adjust to the new rates. Day programs were hit with the full effect from day one. Last year, the legislature, recognizing that the system was underfunded, appropriated additional funds for supported community living programs, but none of that increase went to day programs. To make ends meet, we've had to initiate a number of cost containment activities, including staff layoffs. About half of our folks are at Tier 2, and I just heard today, Tier 2 may be losing some funding also. For the first time in our history, over 50 years, we have had to turn people away from our program because their tier assignment won't fund the level of support they need. For us, that is a heartbreaking situation. I'm asking for this committee to review the decisions that have adversely affected day services and treat us the same as all HCBS providers. Thank you.
Thank you, Jim, for your presentation. The next presenter will be Flora Schmidt of the Iowa Behavioral Health Association.
Good morning. I'm Flora Schmidt. I'm the Executive Director of the Iowa Behavioral Health Association. I have emailed my comments to Patty as well as provided them in print for the commission this morning. On behalf of IBHA, we thank you for this opportunity. And secondly, we just want to let you know we represent mental health centers and addiction providers and gambling treatment services across the state, and we do have a presence in all 99 counties. I have 3 key areas I would like to address today, and that is one of them you've not yet discussed because it wasn't part of your agenda, but the substance use disorder was mandated by Senate File 2418. The Iowa Department of Public Health did a work group with this. They met multiple times, and we are in full support of the issues that they discussed. We're in support of the findings they had as well as supportive of their recommendations that came forward. They were looking at whether or not reimbursement provisions were adequate for outpatient and residential treatment. The finding was no. The current reimbursement provisions are not adequate. They looked at, is it appropriate to rebase reimbursement? The finding was yes, it is appropriate and it's needed. They looked at, is there equity in reimbursement compared to the reimbursement methodologies used for providers of similar behavioral health services? They determined no, the current reimbursement methodologies are not equitable. And then finally, they looked at access to substance use service providers, including whether the designated number of CMHCs is sufficient. They found that no, access to substance use disorder service providers is not sufficient, but they did not look or address whether or not the number of CMHCs were adequate. They go forward to recommend that there needs to be equity in the Medicaid reimbursement for similar services, and asking that a provider type be set up for the IDPH Substance Use Disorder Integrated Provider Network that is consistent with the enhanced rates of the CMHCs. Additionally, they are asking that rebase and assure adequate reimbursement for such services happens, and that there is a study brought forward that is on projected cost reporting versus current costs, because they have downsized so much of their costs just to keep their doors open. It is not adequate in covering their services, which is what you've heard from many providers as they come in and associations. Additionally, there needs to be access to substance use treatment by requiring DHS to direct the MCOs to review and revise the Medicaid managed care pre-authorizations for medication-assisted treatment. And we heard a little bit ago that the pre-authorization for Suboxone and MAT is required by the federal government. Per our conversations with IDPH since that comment was made, the Department of Public Health is saying that that is not a Medicaid requirement. It is part of Medicare, but it is not part of Medicaid. And there are several states that already have it in place, and we are urging this to happen. Iowans are dying because of this. Next, what I'd like to do is move into the conversation. We want to make sure there's parity, but Health Homes Review. We attended these meetings. We were actively involved. The charge of that group was to facilitate a work group. This work group did meet We are appreciative of the mandate and therefore charges, yet we have various concerns regarding the fact of the process that was used. This group met twice for 2 hours each time for a total of 4 hours. That is not adequate for the services this group provides. Additionally, we have concern that there is not adequate oversight and contract adherence of the health homes as the lead entity MCOs. We believe that needs to be improved. Changes to the state plan amendment needs to be vetted properly before this does occur. Proposed changes to the payment model from the PMPM to a fee-for-service, it feels like it's going backwards. We're moving forward into value-based payments, and now we want to put CPTC codes on each of the core services. Several of those services, especially transitional care, you will not even have, if you're doing a good job, your clients are not going to end up in the hospital. On the positive side, we're encouraged by the fact that the overall cost of care is trending down. The review of provider files illustrated consistent compliance. The review of member files illustrated consistent alignment. There was a recognized deficiency in the services and technical support of the lead entities, and there was also a recognized need for improvement in communications as well as further analysis. And finally, we ask, do not forget about the fact of timely and accurate payments. Providers are still not being paid on time, being paid accurately, and when this is addressed, what happens is that amount of money gets recouped and paybacks happen, and we end up still waiting to get payments. There's a lot of money sitting on the accounts receivable for providers throughout the industry. Thank you for this opportunity. At your convenience, IBHA would welcome each of you, as well as your colleagues in both chambers, to visit our facilities across the state, as well as we were willing to meet with you one-on-one to discuss the issues and provide data to support our comments.
Thank you very much. I'd like to ask, after the meeting's over today, you come and see me.
I would love to do that. Thank you.
Our next presenter is Shelley Chandler, representing the Iowa Association of Community Providers.
Good morning. I want to talk to you today about the tiered rate discussion that you had earlier. As an association, we are very supportive of the move toward a standardization through the assessment process as well as going to a tiered rate. We've been absolutely supportive of funding the higher needs clients, either those that are medically fragile or behaviorally involved. We're specifically talking about the daily SCL program. I want to acknowledge Jim Fox's point that the tiered rates changes that were made did not impact the day have programs, and I'm only going to be talking about the daily supported community living or residential programs today. The vast majority of clients served in that daily SCL programs are in tiers 2 and 3. 80%, in fact, of the total clients served in daily supported community living are in tiers 2 and 3. So while we certainly understand that we need to support the funding for those higher level need clients, the program is tiers 2 and 3, essentially. And those higher need clients really have become outliers that are expected to be funded within this current system of care. We understand the dilemma of the department to maintain budget neutrality, and we were very, very grateful for the work last year with the legislature to make whole back to fiscal year 2014, adding about 50% of the $15 million that was taken out of funding for services. We're hopeful that that commitment will continue for next year to get us fully back to where we were in 2014. So I want to make a point that this $15 million that we requested was not new money. It was rather to make whole what was taken out back 3 years ago, now almost 5 years ago. In the actuary report, and what Director Randall talked about, was the discussion of cost reports. The cost report is a system that's put into place with prospective rate setting and retrospective cost reporting that's really not an accurate reflection of the real cost of doing business. In fact, in Iowa code, there's a requirement that there can only be a 2% profit margin. That has been in code for a very long time. Those cost reports that came from fiscal year 17 was the first full year of managed care. The vast majority of our providers had negotiated rates that were put in place before managed care. So the cost reports took a look at that new weighted average that was put into place. I'm getting very complicated, but that weighted average goes back to 2014. So it shows an overpayment because we're in 2017, and yet what was approved was the 2014 rates. We are looking forward to working with you going forward next year. But I just want to, in summary, say that originally, as Director Randall talked about, there were thousands of rates. It was an individual rate, and we understand and acknowledge that you can't have that going into managed care. So we moved to this weighted average, which was based on outdated rates. Then we moved to a set of tiered rates that was set by the department that was based on 2014. There was $7.5 million put in July 1st, and now we're moving to another change. So it's been extremely complicated on top of the comments that Flora has made about claims payment and denials and going through the process, the comments that Jim Fox made about the assessment process and case management. There's been a lot of change. We are looking forward to working with you. We are hopeful that you will continue with your commitment for that other 50% of what was lost in 2014, and thank you very much for your work with us.
Thank you, Shelley. Our next comment comes from Karen Walters-Kremen, and she was a member of the Health Home Work Group. Would you please come forward?
Thank you for the opportunity to speak. I'm Karen Walters-Crammond. I've worked in the mental health and disability services system for 40 years. I don't like to admit that sometimes, but I have seen lots and lots of changes over the years, and I think it's a very exciting time that we are in right now because we've seen a lot of efforts put forth to make major changes that have sat on the shelf, and I think that you all have some motivation and energy to move ahead with some of the promising things that are happening. I have worked at the state level, the county level, the regional level, and at the MCO level, and at the provider level. So I have all those perspectives wrapped up in my experience. I did participate in the work group as a subject matter expert. I'm independent right now. I just want to make a couple of comments based on the report this morning. The state plan amendments for the two health home programs do appear to be incredibly similar. And a lot of that has to do with the fact that CMS prescribes a template for those state plan amendments. So, and they even define what are those 6 core services. But when you look at the actual state plan amendments and dig down into the definitions of those 6 core services, the types of providers between the chronic condition health homes versus the integrated health homes, and you look at the target populations, there are significant differences between those state plan amendments. And it's actually by design because of the differences in the populations that are being served and the types of providers that are included in those amendments. And also integrated health homes replaced targeted case management, which doesn't exist on the chronic condition health side. It's really important that the level of interaction and care coordination within that integrated health home state plan amendment be preserved. There's also a great deal of overlap in the 6 core services in the state plan amendments, and there should be no preconceived notion that the amount of each of those core services would be equal. As Flora pointed out, if an integrated health home is doing a good job in keeping people out of the hospital and out of the emergency rooms, there should be little need to provide the core service of transitional services. So it's a good thing if there isn't a lot of that going on, if there aren't the hospitalizations and emergency room visits going on. Moving to separate CPT codes for those 6 core services will unnecessarily increase the administrative burden on the health homes. It will also take the integrated health homes out of the little bit of value-based purchasing that exists on the behavioral health side. And that the direction, as you've been hearing, the whole healthcare industry is moving towards value-based purchasing, so why would we take a step backwards? I appreciate that the department recognizes that further study is needed, and I encourage them to conduct the further analysis of compliance with the spas and of the quality measures before moving ahead with either of these changes, the changes to the spa or going to separate CPT codes for billing. I also encourage the department to, as they do these further studies, to look at the chronic condition health homes and the integrated health homes as the separate programs that they were designed to be. The study mushes the data, and it also is the part of the study, it wasn't a study, it was the part of the review that was done using member records. The number of records looked at was less than 1% of the integrated health home population and 1% of the chronic condition health home. So definitely we need more study before taking actual policy action to see what, there may be something less drastic that can be done to take care of the concerns that were raised by that report. Thank you.
Thank you very much, Karen. Our last presenter today is Ashley Thompson with Unity Point Health.
Hi there, good morning. My name is Ashley Thompson. I'm part of the Government and External Affairs team with Unity Point Health. I think some of you may remember from our last meeting a couple of weeks ago, Saber Rosner, who's our vice president, came and spoke to you about value-based purchasing and the work that our health system has been doing for a number of years in the Medicare space. So I'm going to speak a little bit about that today in terms of the Medicaid space and the work that we're doing. So first, part of my role at Unity Point Health is working specifically with behavioral health. And so I work very closely with 5 community mental health centers that are affiliated with us. That includes the Berry Hill Center in the Fort Dodge region, Abbey Health in the Iowa City and Cedar Rapids region, Black Hawk Grundy Mental Health, which is in Northeast Iowa, the Robert Young Center, which is in the Quad Cities, and then finally Irely Ball, who serves Central Iowa. All 5 of those community mental health centers are also IHH providers in the state, and as I've spoken last year at the Health Policy Oversight Committee, our 5 IHH providers account for about 25% of the entire IHH population in the state. So there's 35, I think, IHH providers. Unity Point Health constitutes 5 of those, and we take care of the quarter of the state's population. So this is really important for us. Not only are those members who served by community mental health centers, but we're certainly seeing them on the primary care side through Unity Point Clinic. Sometimes those folks are coming and seeing us in our inpatient units or outpatient facilities. So again, as being a large nonprofit integrated delivery system, this is a key program for us. I want to spend a few minutes and first of all thank Director Foxhoven, Director Randall, Deputy Director Steer, and folks behind me for the opportunity for the work group to come together. I was fortunate enough to be a member of that. We really appreciate the opportunity to be able to provide the feedback on both health homes. I think it is important for us, first and foremost, with all of the talk about pre-authorizations and other things, to really point out some of the successes that we found in this report. Just a couple of pieces considering compliance around the IHH program. The report did note that 100% of IHHs contain evidence of quality improvement activities. As Director Foxhoven and Director Randall noted, and as you'll see in the work group report, none of the quality or patient experience data was included in this work group report, and we very much appreciate that moving forward that's going to be work that we'll continue to do together to provide a more holistic view of the great work that IHH providers across the state are doing. But I just wanted to point out that for our 35 IHH providers, this is really important, and I think that they're all demonstrating performance and quality improvement is something that this work group should be aware of. Another piece is nearly all IHHs are, and that's 97%, are in process or are currently using electronic health records. Again, another critical piece for providers both in the primary care space as well as the behavioral health space, that we have electronic health records, which helps us gain that data and have a better understanding where these patients are going and how that services are being provided. I will reflect just in a couple of points. We really want to make sure that we're pulling in that quality and patient experience data before any changes are made to the state plan amendment. And I think that's a recommendation that's clearly articulated in the work group report, but want to make sure that we point that out. And then finally, just for some of our IHH providers, I've had the honor and privilege of being able to go out and spend days and weeks with these folks and seeing how that they're taking care of patients. Specific to Unity Point Health, we're really fortunate our IHH members or providers have access to our Epic electronic health record, and I've been able to see firsthand when you have access to data and if patients are coming in and out of the emergency department, having access to that data is helping us drive down cost. We have internal data that's showing less number of patients coming into EDs, less number of inpatient stays in behavioral health units. So I encourage this committee to continue to support Director Randall and Foxhoven, DHS and IME to further evaluate the program before any changes are made. Thank you.
Thank you. Well, that wraps it up for today. Are there any comments that the members of the committee would like to make before we adjourn? I see Senator Mathis.
Well, the one comment, thank you to everybody who came today and testified and all the great information that we received today. But I'd like to address my comments to you. Representative Heaton, thank you so much for your leadership around all health issues, both in policy and appropriations. We have certainly enjoyed your leadership, and I think everybody across the state of Iowa has benefited from it. So thank you for your years of service and the attention to detail and the tours around the state. You put a lot of mileage on your car, so thank you very much for your work.
Well, I have to agree with Senator Mathis. We in the Senate didn't get our chance to say any goodbyes to you, and so I just remember when Tinsman and Peggy and Heaton and Reagan made some trips, and that kind of working together was really impressive, and you taught me a lot about working with each other, and you will certainly be missed by many of us, and we enjoyed working with you on so many levels, and both in the legislature or afterwards, having an enjoyable discussion about the issues continuing. So thank you for all you've done, and I hope you have a place to use your talents after this.
Representative?
Thank you, Representative Heaton. So 2 things I want to say is, first, I wanted to thank you for including the dental for the meeting today. I know that was a suggestion I had last time, so I appreciate you including them on the agenda today. I just also want to say how much I've appreciated working with you. It's going to be an odd legislative session this year without having a Heddens Heaton or a Heaton Heddens bill being sponsored. So I think we've had one just about every year that we've worked together. So I appreciated the opportunity. I hope to cross our paths because I know you're on the board of directors for NAMI, so I'm sure we will have times that we are discussing mental health, and thank you for your service.
Is there anyone else?
I'd just like to echo kind of all the other comments said today, Dave, that it's been a pleasure and honor working with you over the past 6 years I've been here at the legislature, and your wisdom on this, the topics related to human services are going to be missed here at the Capitol, and we want to thank you for your service to the state of Iowa.
Well, I'd like to thank you for all the nice things you said to me today. To me, it's always been a bipartisan movement on this committee. We've always worked together for the betterment of all Iowans. Those trips were really neat. I really appreciate that. We traveled around the state and visited different providers, institutions, and whatever, but along the way, we continued to talk about other things, common things that we needed to maybe address and work on when the session began afterwards, after the trips. Family First is coming to this state in a year and a half, and I can remember the trip you were on, and the rest of the staff and some legislators, Rofegi and I, Kinsman, who else went? Did you go? Okay, and we saw firsthand Family First, the way they want to do it. And that is, we go to we go to family wraparound services, preserve the family if all possible, and maybe through a licensed foster care or kinship care if we can't pull the family and home together. So we've been there, we've seen it. There is, and I talked to the provider community, there is no reason to panic here. Wisconsin's been doing it, and Minnesota's been doing it for a long time. And so I'm going to miss being on the legislative side of somewhat I consider some of the biggest opportunities, biggest bills on an agenda for this coming session that I've ever seen. You guys, all of you, are going to be really lucky to be able to really make some big time changes in your state. Mental health, by putting in these middle services, these mid-level services, it's going to be challenging, but at the same time, if we're successful in constructing and sustaining these services, Iowa's mental health system will make giant leaps forward and have one of the finest mental health systems in the United States. I'm firmly aware of that. And children's mental health is the law. And we'll get that job done also. Family First is coming, and we'll get that done also. So, folks, you got a full plate, and I wish you well. And thank you all out there for your work and advocacy on the issues that you represent also. Pleasure to be with you, pleasure to work with you, and I'll be joining you on the other side. Thank you very much for coming.
And the legacy.
Good, how are you? You haven't believed this, but like literally 10 minutes before I left the house, the FedEx came. You have a problem with me handing it to you here? So